morning to all of our competitors, our Academic Competitions Committee, Conventions Committee, and the National Executive Board. Welcome to the 5th National Academic Competitions and National Clinical Pathologic Case Conference Competition. Powered by Lecturio, Top-Notch Medical Board Prep, One Platinum, MIMS, Black and Red Merch, and the Philippine Society of General Surgeons. Made possible by Mask Habit. As a reminder, if you are having some trouble connecting to this meeting during the competition, please feel free to message us on your respective Telegram channels with our organizers. Now, please settle down as we begin the program. Please rise for the national anthem, led by the University of the East Ramon Magsaysay Memorial Medical Center, College of Medicine's Chorus Medicus. Let us now remain silent for the opening prayer led by the University of the East Ramon Magsaysay Memorial Medical Center, College of Medicine's Chorus Medicus. Thank you to Chorus Medicus for leading the Philippine National Anthem and today's opening prayer. And of course, welcome once again to all of our competitors. This is the 5th APMC-SN National Academic Competitions and National Clinical Pathologic Conference Competition. Powered by Lecturio, Top-Notch Medical Board Prep, One Platinum, MIMS, Black and Red Merch, and the Philippine Society of General Surgeons. Made possible by Mask Habit. To officially open our program, it is with great pride that I introduce to all of you the National Academic Competitions Committee Chairperson, Ms. Geraldine Valle.
To our panel of judges, our dear competitors, our fellow organizers, and to the National Executive Board, a pleasant morning to all of you. On behalf of the Academic Competitions Committee, we would like to congratulate all the finalists in this year's National Clinical Pathologic Case Conference competition. Annually, we hold our APMC-SN National Convention for medical students to convene and compete in various academic competitions, one of which is the National Clinical Pathologic Case Conference competition. It is quite unfortunate indeed that for the second time around, we are still conducting academic competitions online, as it would have been more exciting meeting you all personally. But amidst the unfortunate circumstance that we are in, I hope that all of us still have a great time and enjoy the competition as much as we organizers did. Once again, good luck to all of our competitors and may the best team wins. Thank you and good morning.
Thank you to our National Academic Competitions Committee Chairperson for officially opening our event today. Today is really an exciting time for all of us to see all competitors from different medical schools across Luzon, National Capital Region, South Luzon, Visayas, and Mindanao. I'm pretty sure all of you are excited to get in the zone, but before we proceed, let us first introduce our panel of judges for this year's CPC competition. Our first judge is a Professor 2 at the University of the Philippines, Manila, College of Medicine, Department of Anatomy, and was awarded with the following: UPMASA Most Outstanding Teacher in Basic Sciences for 9 times, Dr. August D. Camara Most Outstanding Teacher for 6 times, UPMASA Most Outstanding Teacher in LU4 Neurosciences, Academic Year 2020 to 2021, and UPMASA Most Outstanding Teacher in Clinical Department Academic Year 2017 to 2018. He graduated cum laude with a Bachelor of Science in Psychology from the University of the Philippines, Diliman, and graduated Doctor of Medicine in the University of the Philippines, Manila, College of Medicine. Ladies and gentlemen, we have Dr. Jose Leonard Pascual. Unfortunately, we have been informed that Dr. Pascual has urgent commitments today, thus he is unable to attend today's competition. However, he offered to judge the participating team's oral presentations in an asynchronous manner based on the recording of today's event. Okay, moving on. Our next judge is a Bachelor of Science by Basic Medical Sciences Intermed program at the University of the Philippines, Manila, and had her Doctor of Medicine in the same institution. At present, she is a clinical associate professor at the University of the Philippines, Philippine General Hospital. She is also a consultant in Manila Doctors Hospital, Medical Center Manila, Medical Center Taguig, and a consultant and residency training officer at St. Luke's Medical Center, Global City. She is a visiting consultant at Medical Mission Group Specialty Clinics, Calibo, Aklan. A member of the Research Committee for Pediatric Residents at the Manila Doctors Hospital, and a member of the Research Committee for UP-PGH Department of Pediatrics. Ladies and gentlemen, we have Dr. Andrea Aurel Valle. Our third judge graduated Doctor of Medicine at Far Eastern University, Dr. Nicanor Reyes Medical Foundation. He had his residency training in pediatrics at FEU NRMF Hospital, Department of Child Health, attaining the rank of Chief Resident, and his fellowship training in neonatal and pediatric intensive care through Nellie Kellogg Van Schleck Scholarship Grant at Queen Mary Hospital, University of Hong Kong. He also had a Master of Arts in Special Education, major in Diagnostic Assessment and Early Intervention, De La Salle University, Taft, Manila, a Master in Health Professions Education at National Teacher Training Center, University of Philippines, Manila, and is a head of the Department of Pediatrics, Chinese General Hospital, College of Medicine. Ladies and gentlemen, without further ado, let us all welcome Dr. Rodolfo Nang. Lastly, the pathologist of our case is a woman of excellence and has an outstanding track record. The Philippines has only two forensic pathologists, and we are fortunate enough to have one of them to present to us the final and complete diagnosis of this case. She received her training and education from the University of the Philippines College of Medicine. In 2010, she was given the Distinguished Service Award by the Philippine Society of Pathologists. In 2016, she received the Pathologist of the Year award from the same medical society. In the following year, she was awarded the Librorio Gomez Medical Award, the highest award given to a pathologist by the PSP, as a recognition for her advancement and promotion of science of pathology in the fields of medical education, research, and professionalism. Now, she is affiliated with Philippine General Hospital, Manila Doctors Hospital, and St. Luke's Medical Center. She is also an active member of the Philippine Society of Pathologists and the American Academy of Forensic Sciences. With great pride and honor, let us give our loudest virtual applause as we welcome Dr. Maria Cecilia Lim. Now, let us proceed with the reading of our clinical case. May I now give the floor to our National Academic Competitions Committee Chairperson, Ms. Geraldine Valle.
So good morning, everyone. For the clinical case, this is a case of a 7-year-old female presenting with a chief complaint of post-ictal loss of consciousness. For the history of present illness, 1.5 months prior to admission, an insect lodged inside the right ear of the patient. Consult was done and otic drops were given. The insect was allegedly not removed. 2 days after, there was intermittent fever with no associated vomiting or difficulty in ambulation. 1 month prior to consult, she had decreasing appetite and generalized body weakness, and there was no fever or cough and colds. 2 days prior to admission, due to poor performance in school, the mother slapped the child and shook her by the shoulders. After the incident, the child remained functionally unremarkable. 1 day prior to admission, her parents observed stiffening of the extremities and upward rolling of eyeballs with preferential gaze to the left, lasting for 5 to 8 minutes. The episode ended while the patient was in transit to hospital. A few minutes after arrival at the hospital, another seizure episode occurred, lasting for 5 minutes. The first dose of diazepam 5 mg IV and phenytoin 30 mg IV was given. A third episode occurred and patient was given diazepam. The patient became unresponsive with no spontaneous respiration. She put on continuous ambu-bagging and the patient was transferred to PGH. For the review of systems, there were no other systemic symptoms that were present in the patient other than those already mentioned. For the past medical history, the patient had dengue fever at 2 years old and she did not have asthma, allergies, tuberculosis, congenital diseases, surgery, or any blood transfusion. For the family medical history, there is hypertension in the father's side and diabetes, and there is no other history of heritable diseases in the family. For the immunization history, the patient had completed immunization for BCG, Hep B, DPT, measles, and OPV. For the nutritional history, patient was breastfed for 1 month only, after which she was formula fed. Patient allegedly did not have any food preferences. For the developmental history, the patient was an honor student during kindergarten and first grade. For the personal and social history, the patient lives with her father, who is a 31-year-old maintenance electrician, mother, who is a 31-year-old housewife, and a 2-year-old younger sister. For the course in the hospital, the patient was received at the emergency room comatose with no spontaneous respiration. She was hypotensive with a BP of 80/40. tachycardic with a heart rate of 120s with 97% O2 saturation while on continuous ambu-bagging with O2 support at 10 liters per minute. Weight was 22 kilograms. Physical examination showed multiple hematomas on the upper extremities, abdomen, and lower extremities. Neurologic examination showed pupils that were fixed and dilated at 8 millimeter, but fundoscopy did not show any hemorrhages or papilledema. There were no spontaneous movement and response to pain of the extremities. There was also no Babinski sign, and deep tendon reflexes were positive 3 on all extremities. There was no Dahl's eye and no gag reflex. Other than the described physical examination findings, the rest of the systems were unremarkable. She was intubated with tab and IV bolus of plain NSS at 20 cc per kilogram, was instituted with improvement of BP to 90/60 and heart rate to 108 beats per minute. However, the blood pressure dropped to 70/40 after 3 minutes and O2 saturation dropped to 73%. Another plain NSS IV bolus was given with improvement. Laboratory tests were done and CT scan showed subarachnoid hemorrhage with diffuse cerebral edema. After the CT scan procedure, the patient coded and was revived after 4 minutes. Inotropic support with dopamine and epinephrine was started. She was transferred to the ward, and upon admission, she was still hypotensive with a BP of 80/40 and tachycardic with a heart rate of 130. Chest auscultation now revealed crackles on bilateral lung fields, and she was given 20 cc per kilogram plain NSS IV bolus. Fluid intake and output monitoring was input of 3,000 ml, output of 4,250 ml. Monitoring of fluid intake and output, serum, and urine electrolytes and urine-specific gravity were done. Her medications included ceftriaxone, famotidine, diazepam, paracetamol, dopamine, dobutamine, norepinephrine, and epinephrine. She was hooked to a mechanical ventilator. On the second hospital day, 3 units of vasopressin via subcutaneous was given with resulting decrease in urine output. EEG was done and showed low voltage cerebral activity. There were still episodes of hypotension with a BP of 80 palpatory with tachycardia, heart rate of 170s, and IV plain NSS bolus was given and inotrope drips were increased. However, there was persistent hypotension. The patient coded again but was revived after 4 minutes. At 12:40 a.m. on the third hospital day, the patient coded, revived after 1 minute, after which she coded again. However, she was not revived. Time of death declared at 12:52 a.m. with the clinical cause of death as indeterminate. For the CBC results on the first hospital day, WBC was at 23.30, RBC was at 4.35, hemoglobin at 124, hematocrit at 0.371, MCV count at 85.3, MCH at 28.6, MCHC at 335, RDW at 12.2, platelet count of 209, and neutrophil count of 0.89, lymphocyte of 0.046, monocyte of 0.063, eosinophil 0, and basophil 0.001. For the coagulation parameters, prothrombin time, PT reference was 11.8, and patient's value was at 12. Percent activity was 0.74, and INR was 1.04. For the APTT reference is 35.6, and the patient's value was noted to be 43.4. For the serum chemistry, for glucose, at the first hospital day, it was noted to be 7.37, 18.29 on the second hospital day, then 7.71 on the second hospital day at 11 p.m. For BUN, 1.10 on the first hospital day, 1.50 on the second hospital day at 9:38, then 2.20 at 11 p.m. For creatinine, 49 at the first hospital day, 89 at the second hospital day, then 141 at the second hospital day at 11 p.m. For AST and ALT, 23 and 19 respectively. For TB, DB, and IB, 12.0, 2.8, and 9.2 respectively on the first hospital day. For calcium and magnesium, 2.49 and 0.83 on the second hospital day, and sodium, 174 on the second hospital day at 9:38, 154 on 21, and 171 on 11 p.m. For potassium and chloride, for potassium, second hospital day, it was 2.5, then 2, then 2.3 at 11 p.m. Then finally, for chloride, 146 for the second hospital day, 136, then 140 at 11 p.m. Lastly, for the ABG, for the temperature, it was noted to be 36.8 on the first hospital day, 37, then 37 on the second hospital day, 36.5, then 36.2. For hemoglobin, it was 12 from the first hospital day until the second hospital day, then 13.9, then 12.2. For the FiO2, it was 60 on the first hospital day, then 100 on the second hospital day. For the pH, 7.525 on the first hospital day, 7.027, 7.1.123 on the second hospital day, 7.135, then 7.290. For the PCO2, 10.3 on the first hospital day, 61.6, 50.4 on the second hospital day, 46.7, then 38.2. For the PO2, 92.6 on the first hospital day, 63, then 147.8 on the second hospital day, followed by 110.4, then 32.5. For the HCO3, 8.5 on the first hospital day, followed by 16.2, then 16.5 on the second hospital day, 15.7, then 18.3. For the BE, negative 9.9 on the first hospital day, followed by negative 15.5, then negative 12.9 on the second hospital day, followed by negative 13.6, then negative 7.4. For the O2 SAT, 97.7% on the first hospital day, followed by 76.4, 97.9 on the second hospital day, followed by 96 and 54. For TCO2, 8.8 millimoles per liter on the first hospital day, followed by 18.1, then 18 on the second hospital day, followed by 17.1 and 19.5. Then finally, for the SBC, 16.6 on the first hospital day, followed by 12.3, then 14.4 on the second hospital day, followed by 14.1, and finally 17.7.
Welcome back, everyone. It seems that we're all set and good to go. With that, let us now formally begin the competition by starting with the first team. Good luck to all.
Good morning. We present you a case of post-ictal loss of consciousness in a 7-year-old female, and here are the salient features. History of insect lodge in the right ear, intermittent fever, decreasing appetite, generalized body weakness, poor performance in school, history of non-accidental trauma, seizure, and post-ictal loss of consciousness. On admission, the patient presented with coma, no spontaneous breathing, hypotension, absence of Gog's and Dahl's eye reflex, as well as no spontaneous movement and a response to pain, which led us to diagnose the patient as brain dead. On top of this, the patient also exhibited hematoma in the extremities and abdomen, bilateral lung crackles, diuresis, tachycardia, acute kidney injury, subarachnoid hemorrhage, and electrolyte derangements. The characters of the seizure are stiffening of the extremities and upward rolling of eyeballs with preferential gaze to the left, with no regain of consciousness. With this, we classify the seizure as focal unaware, originating in the right hemisphere that could have involuted into generalized seizure. With 3 episodes each with 5 to 8 minutes duration, this could be classified as status epilepticus. Could it be that the patient had hypoxic ischemic encephalopathy, secondary to status epilepticus, or to secondary causes? With this in mind, we then proceeded with the etiologies of seizure and loss of consciousness, dividing it into primary CNS pathology and secondary CNS involvement. The CT scan revealed a subarachnoid hemorrhage, thus ruling in primary CNS pathology involving vascular component. With this finding, we then proceeded with causes of subarachnoid hemorrhage, traumatic versus non-traumatic. Under traumatic, we have differential of traumatic brain injury because there is a history of trauma in the form of slap and shake. Also, physical examination revealed multiple hematomas in abdomen and extremities. Hematoma in such protected sites prompt us to consider child abuse. Even if the element of neglect and fractures in the usual areas that are involved in such cases are lacking, we cannot totally rule it out. In traumatic brain injury, there are gray areas that should be addressed. Was the trauma strong enough to produce a subarachnoid hemorrhage? If not, does it mean that it could be secondary to an underlying condition? Thus, we also ventured the non-traumatic causes. AV malformations and aneurysm, these fragile arteries have a high predisposition towards rupture. This can be missed with CT imaging, but the usual presentation of AVM is intracranial hemorrhage. Aneurysm can present as subarachnoid hemorrhage. In the event of rupture, both would present with a typical symptom of headache, which our patient did not complain of. Also, both are in the pediatric population, usually occurring at 20 to 50 years old, thus making them less likely. Hemophilia was ruled in because of the patient's prolonged APTT and hematoma on her abdomen and extremities. However, for a female to manifest hemophilia, a female should inherit two identical hemophilia alleles. This means that the father could be hemophiliac and the mother could be a carrier, but the family history is unremarkable, thus ruling it out. We ruled in lymphoma and leukemia due to the high level of WBC, multiple hematomas. Leukemia is less likely because it usually presents hyperleukocytosis. Also, the patient's RBC count, its indices, and platelet counts are within normal range. Lymphoma is ruled out because of no significant symptoms in other systems such as masses and pain. In addition, lymphoma shows predilection to males. Bacterial meningitis was ruled in because of the history of the insect lodging in the patient's ears and the leukocytosis with neutrophilic predominance. This could be an infection that might have produced otitis media that was unmanaged and thus subsequently leading to meningitis. However, there was no presentation of post-auricular swelling and vestibular symptoms, and the physical exam in HENT was normal, making this unlikely. Based on the SIRS criteria, the patient fits septic shock, but it can be ruled out because it lacks focus of infection. We ruled in primary hyperaldosteronism, also known as Conn's syndrome, based on the electrolyte derangement of the patient. But the triad of Conn's syndrome was not met with the patient's ABG presenting with metabolic acidosis. We ruled in diabetes insipidus, based on the patient's negative fluid balance indicating diuresis and high serum osmolality. Nephrologic cause could be ruled out because there is a response to vasopressin. Central causes include significant trauma, surgery, infiltrative disorders, and tumors affecting the hypothalamus and pituitary glands. The formers are ruled out because of the absence of history. Infiltrative disorders was ruled out because these present with multisystemic symptoms. For the tumors, we have craniopharyngioma and germinoma. Clinical features and radiologic findings of suprasellar tumors may be similar in both. However, we rule out craniopharyngioma because this tumor grows slowly and a wide range of symptoms are often present for a year or more before the diagnosis is established. Thus, we are left with germinoma. Germinoma, the most common malignant tumor causing diabetes insipidus, which grows most frequently in the suprasellar region, more prevalent in Asian descent. And with the fast progress of our patient's condition, a malignant type of tumor is more fitting diagnosis. With the evidence and facts presented to us, the most plausible diagnosis would be germinoma. Germinoma causes diabetes insipidus, which causes the hypernatremia and hypokalemia. Hypokalemia would explain the generalized body weakness of the patient. In the event of hypernatremia, it can cause altered mental state, which lead to the child's poor school performance. Also, cell water outflow and slowed sodium transportation between the blood and the CSF would lead to reduced cerebral and CSF volumes. This results in negative pressure around the brain, leading to venous and capillary expansion, which predisposes a vessel to rupture. Thus, the simple slap and shake made by the mother could have triggered a subarachnoid hemorrhage, subsequently causing the cerebral edema, leading to seizure. The increased intracranial pressure in cerebral edema causes tonsillar herniation. The rapid herniation of the cerebral tonsils led down through the foramen magnum, compressing the medulla, which distorted and damaged the brainstem and frontal cortex, leading to the multiple clinical manifestations such as apnea, loss of consciousness, and the compression of the oculomotor nerves, causing dilatation and fixation of the ipsilateral pupil. Subsequently, ischemia from the herniation increases sympathetic nervous system activity and releases adrenergic and noradrenergic neurotransmitters, which stimulated the alpha 1, 2, and beta 1 and 2 cells, leading to increased cardiomyocyte contractility, thus tachycardia. The progressive compression of the medulla caused the Cushing's reflex, manifested as deep coma with low blood pressure and tachycardia, apnea, and finally, the death of our patient. Thus, for immediate cause of death, tonsillar herniation. Antecedent, subarachnoid hemorrhage and cerebral edema, underlying germinoma, contributory child physical abuse. Thank you.
Thank you to our first team. Let us now call our first judge for the question and answer portion. May we call on Dr. Andrea Valle.
Thank you for that very interesting presentation. Okay, kind of strange. Okay, very nice visually. My question is, with the course of the patient, the timeline fit with the germinoma?
Yes, Doctor. Thank you for that very wonderful question, Doctor. With the timeline of the patient, we theorize, Doctor, that it fits germinoma, especially that this is a malignant type. Also, Doctor, when we say it fits, it actually presents with diabetes insipidus, thereby producing the symptoms of the patient, such as the generalized body weakness, and as well as the poor school performance that might have caused, that was caused by electrolyte derangement, Doctor.
Okay, sige. Okay. Did the patient have any increased urine output, or was there any evidence of increased urine output?
Yes, Doctor. There is an evidence of increased urine output in our patient during the hospital stay. We have a negative fluid balance of more than 1,250. And also, Doctor, we are theorizing that the patient may have been suffering polyuria already prior to the admission. It was just not present within the history of the patient, because as you know, Doctor, pediatric history is the history are taken from the informant. Therefore, only the front symptoms would be taken note of by the parent, Doctor.
All right, thank you.
For our next judge, may we call on Dr. Rodolfo Nang.
Yes. Okay, thank you for that wonderful presentation. Now, my questions will be more related to the history that was presented. Number one, what else would you like to ask from the family history? Do you think,
yes, Doctor.
What else? What else would you like to ask pa?
I'm sorry, Doctor. First and foremost, Doctor, we would like to ask the mother with regards to the triad of the diabetes insipidus. Namely, if the patient has having polyuria and nocturia, and there's a triad. Sorry, Doctor.
I'm asking for family history.
Oh, okay, Doctor.
Yeah, sige, go ahead.
Okay, Doctor. With the family history, Doctor, we would be asking with regards to better enlighten or to better strengthen our differential diagnosis. We would be asking with regards to the history of we would be asking to characterize more on the history of hemophilia, if they would be having one. Predisposition to, family history of cancers to relatives, as well as family history, Doctor, of the causes of their hypertension, if it was characterized on what caused this hypertension.
Remember, your patient is a female. So do you think family history of hemophilia will be relevant?
Yes, Doctor. As we have said in our in the way we rule out hemophilia, we would like to still strengthen it, doctor, because if we discuss how we would eliminate hemophilia in females, the male should be a carrier, the male should be a hemophilia, and the mother should be at least a carrier for the offspring of a female to manifest a hemophilia. But in that case, doctor, we still would like to characterize a history of bleeding as well as the history of hypertension of the patient on what caused it. I mean, hypertension in the family of the patient and what might have caused it.
So just to test your what you already know about immunization, it was stated they're completed. Do you agree? So I presume that this girl received her immunization from a health center. So do you agree completed siya?
Yes, doctor, we agree that the patient will be has a history of completed vaccination. However, doctor, we could not disregard the point that maybe these vaccines were somewhat in failure or failed in the population because there is still that kind of risk when it comes to the vaccination, doctor. Thank you.
Okay, thank you.
For our last judge, may we call on Dr. Maria Cecilia Lim.
Thank you, Group 1. That was a very interesting take on the case. I have two questions for you. The first one is, would you expect the germinoma to show on the CT scan?
Doctor, thank you so much, doctor, for that very wonderful question. And we have actually really searched hard on that part. You know, doctor, there are works that have been published already, especially in the works of Podesta and Adams as well during 2018. They said, doctor, that a routine CT scan or a non-contrast CT scan cannot fully rule out germinoma, doctor, especially if especially if the purpose of the CT scan is only to rule out bleeding. So the way that we should be requesting CT scan or the way that we should be requesting MRI to be for a better imaging, we should be telling or requesting rather a pituitary concentration focus on the CT or MRI, doctor. Thank you.
Thank you. Okay, your second question is, I was looking at your causes of death statements.
Yes,
Where
doctor.
I think you said that you were entertaining diabetes insipidus in this case?
Yes, doctor.
I don't see it in your final diagnosis. Why did you put your immediate cause of death as tonsillar herniation instead maybe of the diabetes insipidus?
Yes, okay,
What
doctor.
made you weigh? How did your brain go when you were weighing what you would put in the immediate cause of death, for example?
Okay, doctor. We believe, doctor, that the immediate cause of death should be what happened prior to the death of the patient. So we were thinking, doctor, that this is how we thought about it, doctor. So the germinoma caused diabetes insipidus, and the diabetes insipidus in turn a hypernatremia. This hypernatremia, doctor, caused a hypertonic environment that would have caused the outflow of fluid outside the brain, thereby rendering this brain to be a little shrinking, and then it would be a little, swaying away from the skull. So that's one point, doctor. And also with regards to the hypertonicity and what happened to the brain, this could have caused a vascular bulging. So remember that I'm saying that the water in the brain and CSF actually were concentrated in the vascular. Therefore, it has a predisposition towards rupture. When the patient was slapped by the mother and shaken by the mother, we thought that this could have been the predisposing, the triggering factor towards the subarachnoid hemorrhage of the patient. And during the subarachnoid hemorrhage, doctor, we produced cerebral edema, thereby with the speaking towards the Monroe-Kelly doctrine, we believe that the patient have a manifested increased intracranial pressure that could have pushed, doctor, the tonsillar portion of the cerebellum towards the medulla, and it is actually fitting, doctor, to our case because the patient actually have hypotension and and among others that have led to the death of the patient. So we thought, doctor, that it's tonsillar herniation that really caused the death of the patient.
Okay, thank you.
Thank you so much, doctor.
Congratulations to our first team for their presentation and finishing the Q&A portion. Thank you as well to our panel of judges for your questions and insights. Welcome back, competitors. Let us now proceed to our second set team.
Welcome to our case presentation. Our case is a 7-year-old female who came in due to post-ictal loss of consciousness. The following are the salient features: 1.5 months history of unremoved insect and intermittent fever which occurred 2 days later and resolved spontaneously. 2 weeks after, there was decreased appetite and generalized body weakness. 2 days prior to admission, had onset of altered mental status, and a day prior to admission, status epilepticus, as there were 3 seizures that resulted to unresponsiveness and absent spontaneous respiration. The patient had a GCS of 3, no Dahl's eye, and absent gag reflex. Upon initial examination, there was hypotension with a blood pressure of 80/60 and tachycardia of 120. Multiple hematomas found on the abdomen, upper and lower extremities. Based on the onset and relevance of the history and PE findings, we considered the 3 most likely classes of etiology. Our differential diagnosis for the post-ictal loss of consciousness are as follows. Under metabolic, we have electrolyte imbalance. Under vascular origin, we are considering intracranial hemorrhage. Under infectious causes, we are considering brain abscess and meningococcemia. Under non-infectious, we have hypoxic ischemic encephalopathy. Now, let's identify and localize sedation. Is there an organic lesion? With the patient's signs and symptoms, we can confirm the presence of an organic lesion with acute manifestations of symptoms. We suspect the lesion involves the central nervous system due to the symptoms pointing to a cerebral lesion, such as altered mental status, presence of seizures, and loss of consciousness, which can then be localized with the cortex, brainstem, and a possible meningeal involvement. When the patient arrived on day 1, she was in a coma. Her blood pressure was initially 80/40 with a heart rate of 120. There was persistent hypotension, initially unresponsive to fluid challenge, but warranted subsequent initiation of inotrope support. The initial lab tests had remarkable leukocytosis with neutrophilia, signifying that there is ongoing sepsis. By this time, we confer that an infectious cause is more likely. There were hematomas seen in the patient, and along with a marked prolonged APTT and slightly prolonged PT, the presence of disseminated intravascular coagulation in the patient can be concluded. DIC develops in about 35% of patients with severe sepsis. The cranial CT scan revealed subarachnoid hemorrhage with diffuse cerebral edema. Therefore, we ruled out brain abscess, and this confirms our initial impression that there is indeed intracranial hemorrhage, specifically subarachnoid hemorrhage. The presence of intracranial hemorrhage as found in the patient should commonly result to hypertension, but on the second day, the patient's BP was persistently low despite fluid resuscitation and inotrope support. It can thus be wisely surmised that there may be an injury to the adrenal glands. The adrenal medulla is responsible for catecholamine production, and failure to produce such can explain the persistent hypotension. With this data, and our consideration earlier of an ongoing sepsis that caused DIC, a hemorrhagic complication involving the adrenal glands is most likely. The Waterhouse-Friderichsen syndrome is highly likely in the patient. The fluid intake and output was reported to be 3,000 ml and 4,250 respectively. 3 units of vasopressin were initiated and response was noted through a decrease in her urine output. The laboratory findings, on the other hand, revealed hypernatremia, hypokalemia, and hyperchloremia. The constellation of these findings, electrolyte imbalance, increased urine output, and the patient's response to vasopressin is highly suggestive of central diabetes insipidus. Central DI can result from any brain injury, and the subarachnoid hemorrhage may have possibly caused this. Since the electrolyte imbalance is an aftermath, it could not have been the source of the neurologic decline. Its sole presence cannot also explain the intracranial lesion found in the patient. Therefore, while it contributed to the patient's signs and symptoms, it is unlikely the patient's underlying condition. At 12:40 a.m. on the 3rd day, the patient coded, revived after a minute, coded again, but sadly did not make it. Time of death, 12:52 a.m. Taking into consideration our assessments during the course of admission, laboratory, and imaging finding, now you're left with an infectious systemic disease with a high propensity to cause DIC. This makes our final diagnosis as Waterhouse-Friderichsen syndrome in meningococcemia, central diabetes insipidus secondary to subarachnoid hemorrhage. Meningococcemia is an acute fatal systemic disease with a high mortality rate which usually manifests with a purpuric rash, but in severe cases, these can coalesce to form purpura fulminans, which present as multiple hematomas in our patient together with DIC and Waterhouse-Friderichsen syndrome. Surviving bacteria that have reached the bloodstream from either a break in the skin or through the mucous membrane travels through the circulation causing sepsis. Neurologic involvement is owed to the fact that Neisseria carries the necessary virulence factors to enable it to cross the protective blood-brain barrier, causing invasion of the CNS. Predilection of Neisseria meningitidis for the microvascular endothelial cells is one of the major pathophysiological issues in meningococcal infections. This property is associated with the clinical feature of crossing the blood-brain barrier and the formation of peripheral purpuric lesions, which can coalesce and lead to purpura fulminans. This colonization of the vasculature, especially when a large number of vessels by a high number of bacteria as seen in the patient with purpura fulminans, can account for extensive hematoma lesions and thrombosis, as well as the loss of vascular integrity that is also responsible for the severity of the shock. Due to the severe sepsis, DIC occurred. Consumption of the clotting factors lead to hemorrhage and manifests as multiple hematoma in the patient. This dysregulated inflammatory response resulted in seizures and diffuse brain swelling, which was seen in the CT imaging. Involvement of the hypopituitary axis due to the subarachnoid hemorrhage will result in the development of central diabetes insipidus that causes electrolyte imbalance. For the adrenal gland, it is vulnerable to organ dysfunction due to its singular venous drainage. Overwhelming inflammatory processes can significantly cause the disruption of the hemodynamics and cause toxin-mediated vasculitis and coagulopathy. DIC may lead to venous thrombosis in the gland, with consequent hemorrhagic necrosis leading to Waterhouse-Friderichsen syndrome. Loss of normal cortisol production hastens the circulatory collapse. As the patient progresses to septic shock worsened by DIC, the refractory hypotension leads to poor tissue perfusion, which would not meet the demands of tissue for oxygenation. This decline causes cellular and metabolic arrangements that shift from aerobic respiration into anaerobic, with ensuing lactic acidosis and end organ damage. The progression of organ dysfunction, despite the vasoactive administration, will define the state of multi-organ dysfunction. As a result, the patient will ultimately end in death. Our immediate cause of death is brainstem failure secondary to subarachnoid hemorrhage secondary to DIC. As for the antecedent cause, decompensated shock secondary to Waterhouse-Friderichsen syndrome, and our underlying cause is meningococcemia.
Thank you very much to our second team. Let us now call our first judge for the question and answer portion. May we call on Dr. Andrea Valle.
Thank you very much for your presentation. That was very well discussed. My question is, does the patient's history, the timeline of the patient's symptoms, does it fit with meningococcemia?
Yes, doctor, especially when the first seizure attack occurred. It usually fits within the 2-day progression of the meningococcemia, doctor.
Yes, but what about the fever?
Given the fact, doctor, that it is a fulminant meningococcemia.
Sorry?
Given the fact, doctor, that we are also considering that it is a fulminant meningococcemia, and with the fever, doctor, at the first 1 month prior to admission, the fever resolved as stated in the history, doctor.
Doctor, we started with the 2 days prior to admission when the patient manifested with seizure, and by that time we consider a fulminant meningococcemia. The patient, in the history, it's not mentioned that there is fever, but in the course in the wards, the patient was given paracetamol. We still consider meningococcemia in the absence of fever due to the presence of hematoma in the upper and lower extremities and the abdomen, and also in the presence of status epilepticus, which is a manifestation of a systemic or fulminant systemic condition. So we consider meningococcemia because 90% of patients with meningococcemia present with this kind of rashes, doctor.
right, thank you.
Thank you, Doc.
Thank you, Dr. Valiev. Now let's proceed to our next judge. We have Dr. Rodolfo Na.
Yes. Okay. Wala.
Mark,
Yes. All right. My first question is, did the group totally rule out abusive head trauma?
Doctor, we did not rule out an abusive head trauma or even child abuse.
Pero, correct me, I didn't see those remarks about it.
Okay. We did not totally rule it out, doctor, but we are more inclined to in an infectious disease, doctor, since the laboratory finding shows that there is already leukocytosis, which is one of the manifestation of SIRS, and also the presence of the tachycardia, which can also fits in the criteria for SIRS, and then with the additional infection, it will now proceed to sepsis, and at the same time, for severe sepsis, because due to the intractable hypotension.
So that means you are considering infectious because of what? Leukocytosis.
Yes,
Is
doctor.
that right?
Yes.
Can you not think of other possible explanation for that leukocytosis based from the history given? Now that can also lead to leukocytosis.
Okay, doctor. The possible cause of the leukocytosis based on the history is the status epilepticus, doctor, because it can also increase in WBC.
Okay.
But
So in other words, it is a response of what? Yung leukocytosis. Yeah, you're right. It's because of the status epilepticus. No?
Yes,
But it is what? A response to?
It's the response, doctor, to the possible bleeding, doc, in the brain.
Okay. Anyway, last question. Remember from the history, fundoscopy was negative. Despite CT scan shows subarachnoid hemorrhage. So how can you explain that?
The negative papilledema in the fundoscopy, doctor, I will show that there is no increase in ICP, but but we cannot totally rule out subarachnoid hemorrhage that could eventually cause an increase in ICP, because in the patient, the whole body of the patient is already hemorrhagic, as we are considering the IC, doctor. So some of the blood volume will also be distributed to other parts.
So aside from yung papilledema, which was not shown sa fundoscopy, ano pang possible fundoscopy finding in the presence of subarachnoid hemorrhage? Yung papilledema, there is no problem because CT scan showed it, right? Sige. Okay, thank you.
Thank you, Dr. Rodolfo Na. Now let's proceed to our last judge. May we call on Dr. Maria Cecilia Lim. Doc,
sorry, I got it now. Thank you, Group 2. I just have one question. So the symptoms of the patient, you think are more because of the meningococemia involvement of the adrenal glands rather than a central cause of the of a panhypopituitarism or selected?
Doctor,
And why? Yes.
We considered, doc, the adrenals and also the central as a secondary to the entire disease entity that is meningococcemia. So it's for us it was more of a systemic action of the disease rather than just one area than another area. So we considered it occurring at the same time, doctor.
Okay. Okay, thank you.
Thank you.
And thank you to our second team for your presentation and finishing your Q&A. Thank you as well to our panel of judges for your questions and insights. Welcome back, competitors. Let us now call on our third team.
Status epilepticus is a medical emergency that poses a significant risk for mortality among pediatric patients. It can lead to deleterious effects, as can be seen in the case of a 7-year-old female who presented with the chief complaint of post-ictal loss of consciousness. Here is the history lab and imaging findings. Her seizures character and duration, followed by a post-ictal comatose state, are all consistent with convulsive status epilepticus. Generalized seizures typically localize to the bilateral cortex. When accompanied by a localizing sign, such as preferential gaze to the left, the seizure origin is most likely in the right frontal lobe, suggestive of a secondary generalized type of status epilepticus. Initial and secondary therapy in the form of diazepam and phenytoin were given, but afforded no relief. Seizures continued to persist, eventually leading to an unresponsive state with no spontaneous respiration. Seizures that fail to respond to at least 2 first-line meds pertains to refractory status epilepticus, which affects up to 40% of patients with SE and is associated with significant mortality. Causes of refractory SE can be categorized into 4 distinct entities. Given the rapid presentation of the patient's symptoms, an acute symptomatic cause is most likely in this case. Under this etiology, encephalitis and meningitis are considered to be most common in pediatric patients. Among the classic triad of meningitis, only altered mental status is present in our patient, making this disease less likely. Meanwhile, encephalitis can be classified as viral or autoimmune in origin. Both types may have similarities in presentation, but autoimmune encephalitis commonly have atypical symptoms such as psychotic features and uncontrolled muscle movements, making it less likely in our case. Of the common viral entities, herpes simplex encephalitis is the most common type of sporadic enceph, with predominance to HSV1, especially in children. It also has a predilection to occur primarily in the frontotemporal region, explaining the focal origin of the patient's seizures, with secondary generalization. Given this impression, how does this disease explain the pertinent subjective and objective findings in this case? The nonspecific findings of anorexia and weakness may indicate the initial infection with HSV. Meanwhile, patients' poor school performance, contrary to being an honor student, may signify the latent phase, as cognitive impairment may be found in such stage. It can also be recalled that the patient experienced physical abuse by her mother and has presented with multiple hematomas. The psychological and physical stress brought about by the abuse may have triggered the reactivation of the virus, explaining the refractory status epilepticus 2 days after the incident. Moreover, laboratory findings also showed significantly increased sodium levels associated with polyuria and the hyperosmolar state, suggesting diabetes insipidus. The administration of vasopressin on the second hospital day has caused reduction of serum sodium, confirming a central or neurogenic cause for the disease. One of the causes of central diabetes insipidus is an acute infection that can damage the hypopituitary axis, thus affecting vasopressin neurons or fiber tracts. Such an infection, coupled with deficient vasopressin levels, may trigger acute hypernatremia that causes severe neurologic deficits to the sudden shrinkage of brain cells and rupture of cerebral veins, ultimately causing subarachnoid hemorrhage, a phenomenon that is typical in pediatric patients. Taking all this into consideration, our primary working impression is subarachnoid hemorrhage, secondary to hypernatremia, secondary to central diabetes insipidus, refractory convulsive status epilepticus, secondary to herpes simplex encephalitis. This leads us to ask, what are the pathophysiologic mechanisms in this case? HSV causes viral replication in the frontotemporal region of the brain. This leads to decreased perfusion with initial necrosis, thus poor performance in school. Necrosis results to inflammation and subsequent HSV encephalitis. It then establishes latency, which was eventually reactivated
by physical injury and psychological stress. HSV reactivation results in hyperacute release of neurotransmitters, leading to ionic dysregulation, leading to focal, then generalized seizures. Diazepam and phenytoin both were deemed insufficient to stabilize the seizures due to the brain necrosis. All this eventually led to refractory status epilepticus. Left uncontrolled, signals reach the respiratory centers in the medulla, causing apnea and subsequent cerebral hypoxia due to damage to the neurohypophysis, ultimately leading to central diabetes insipidus. This condition resulted to loss of vasopressin secretion, causing decreased water reabsorption and decreased vascular resistance, leading to hypovolemic shock, causing non-anion gap metabolic acidosis. Resuscitation efforts by plain NSS were all insufficient. Shock caused RAAS activation, leading to hypokalemia, and increased sodium reabsorption led to increased serum osmolality, hyperchloremia, and ultimately hypernatremia. Acute hypernatremia caused the eventual rupture of cerebral vessels, causing subarachnoid hemorrhage. This led to systemic inflammatory response syndrome, ultimately leading to vasogenic edema. The aforementioned systemic inflammatory response syndrome explains the leukocytosis and hyperglycemia. Subarachnoid hemorrhage, together with vasogenic edema, cause compression of the brainstem, leading to brain herniation, causing the following focal deficits. Mechanical ventilation was required, explaining your mixed metabolic and respiratory acidosis. All this ultimately led to multi-organ dysfunction syndrome, eventually leading to the patient's demise. For the medical certificate cause of death, immediate cause of death, brain herniation 4 days prior to death, antecedent cause of death, refractory convulsive status epilepticus 4 days prior to death, underlying cause of death, reactivated herpes simplex encephalitis 5 days prior to death. Other conditions contributing to death, multi-organ dysfunction, hypovolemic shock, electrolyte imbalance, systemic inflammatory response syndrome, acute kidney injury, and central diabetes insipidus. Thank you.
Thank you to our third team. Let us now call on our first judge for the question and answer portion, Dr. Andrea Valle.
Thank you for your presentation. That was very clearly discussed. My question is, why did you consider reactivated HSV and not a primary HSV? Primary HSV encephalitis, I mean.
Okay. The reason why we considered latent po, doctor, is that although the patient may have had your signs and symptoms during the prodrome period, we cannot necessarily really correlate when the HSV infection started. So since HSV and herpes simplex virus usually invades the cells via an abrasion or your oral mucosa, it does not necessarily, we don't necessarily know when it has started. However, with the presentation of our patient, with our as stated earlier, it is more in line with the prognosis and the prognosis and what happened to our patient, doctors.
More of specifically for doctor, we were thinking about the timeline of what happened to the patient. So for example, if indeed at the time of the seizure, that was already an active infection, or that was already your primary infection. Initially, we wouldn't have your symptoms of your generalized weakness. That is already a month prior to the onset of the seizures. So we were thinking that specifically because your latent period of your HSV infection would typically last for start around 3 to 10 days after the primary infection. It's already considered that the presentation of the seizures already is in the latent period of the timeline of the disease. So that's why we lean more towards the reactivation, specifically also because there was already an inciting trigger for the reactivation of the virus. which is the trauma that's brought about and both psychological and physical in nature because of the abuse that she has experienced, which was supported by the multiple hematomas in the patient.
All right, thank you.
Thank you,
Thank you,
Doctor.
Thank you, Dr. Valiant. Now for our next judge, let's call on Dr. Rodolfo now.
Yes. As you notice from the protocol, there were what? Presence of hematoma over the upper extremities, abdomen, and the lower extremity. So how can you explain that?
Good morning po, doctor.
Yes.
We related our multiple hematoma probably be secondary to abuse, mainly because we have two main types of hematoma. One is your not one is basically po, doc, yung isa is hindi mo sinasadya, and the other one is intentional, or you're not intentional. Your non-intentional hematomas would usually present at your bony surfaces, which is in line in the upper extremities and the lower extremities. However, your area around the abdomen with the hematoma suggests a more of an intentional type of hematoma, supported by the history that the mother was able to slap her child and as well as shook her child 2 days prior to the events.
Moreover, just to add lang po, doctor, of course, your hematoma can be secondary to anything. But specifically, your hematologic conditions, underlying hematologic disorders can be a consideration for the hematomas. But because of the blood picture of the patient, also because of the bleeding parameters of the patient, that differential is less likely. Thus, also prior to the incident, prior to the seizures of the patient, there was no significant past medical history that indicates a prior disease entity that can correlate to your bleeding disorders nor any connective tissue disorders. It is most likely for our patient that it's secondary to an abuse. That's why we didn't really that's why we considered the hematoma technically not fully contributory to the present disease of the patient or present cause of the patient.
All right. Yung knowing the result of the EEG, right, and the CT scan, can you not rule out already herpes zoster? Herpes simplex, I mean.
I'm sorry po, doctor. Can you repeat?
Yung knowing the EEG result, no? Slow discharge, right? And the CT scan, subarachnoid hemorrhage, can you not totally rule out already herpes simplex encephalitis?
Herpes simplex encephalitis cannot be totally ruled out po, doctor, because one, we need other parameters to be able to do so, such as your CSF analysis. First, we would use your CSF analysis, and based on the parameters given, would be differentiating viral from your bacterial.
Pero sorry, CSF analysis were not done here.
Yes po, doctor.
Kaya nga. So how can you base on that? Na wala naman tayo. Kasi di ba, we are only given this facts, no, based from the case protocol.
Because of the subarachnoid hemorrhage, the presence of the subarachnoid.
Is that a regular finding or no seen in herpes zoster?
It's not. We admitted it's not a typical finding po, specifically in the CT scan of the patient. However, po, doctor, again, there has been this is although we cannot fully correlate the CT scan of the patient to the herpes simplex virus, there was the presence of your hypernatremia in the patient, and because of that hypernatremia, we are considering that the subarachnoid hemorrhage is secondary to the acute presentation or acute increase of your of your sodium levels. Also, of course, we have to correlate everything clinically because of the timeline of the illness of the patient. It's unlikely po, doctor, that it's unlikely po that your subarachnoid hemorrhage or your CT scan findings as well your EEG findings is sufficient enough to rule out the disease. Especially because your illness is viral in nature. Your symptoms are very non-specific initially, and also also in terms of the EEG of the patient po, doctor, that was taken not it was not taken during the active seizure of the patient. It was already taken when she was already in a comatose state. I believe at the second hospital day. That's why we don't think that it's direct or fully explaining the nature of the disease of the patient or the nature of the origin of the seizures of the patient po, doctor. So we really, in our presentation, we really tried to correlate everything to the history of the patient, to the progression of the disease of the progression of the symptoms of the patient po, doctor.
Sige, thank you.
Thank you so much po, Doc.
Thank you very much, Dr. Nam. As for our last judge, may we call on Dr. Maria Cecilia Lim.
Good morning. In terms of frequency, how often would you find herpes simplex encephalitis in the Philippines? Is that the most common etiology in children?
Honestly, doctor, we didn't really see the actual data in terms of the Philippines. We tried to search for actual data specifically. However, in terms, of course, of your regional, because of our region, Japanese encephalitis could be much more, is also common. However, po, doctor, again, we correlated it to the type of seizure of the patient. In terms of practice, of course, we cannot really specify the type of the virus of the patient based just on history alone. However, that's why we are not totally ruling out other viral or viral etiologies such as your Japanese encephalitis. However, po, doctor, because of the type of seizure of the patient, specifically that it has a focal origin that has that is localized to the right frontotemporal region, and which has manifested, which is eventually developed secondary generalized seizures. That is a typical presentation po for HSV encephalitis specifically, according to data, according to, I believe that's Nelson, also pediatrics, na you typically have your lesions on you have a focal origin for your seizures po, doctor. The studies have not explained why your HSV typically has a predilection to the frontotemporal area. However, again, because of the nature, the characterization of the seizure of the patient, that's why we lean more towards your HSV rather than other viral causes of your encephalitis.
Okay, I'm looking at your MCCOD, and if you're not really sure or you were not able to isolate anything, if you're diagnosing encephalitis, you actually cannot put the organism on the death certificate. Well, you can put question marks. And as for your other significant conditions contributing to death, it looks as if everything that you wanted to put in your cause of death statement, which you couldn't fit into the cause of death statement, you put in the other significant conditions. This is actually incorrect. So all of those things actually put there should not be there. Otherwise, okay, I think that's it. Thank you.
Thank you. We'll take note of that. Thank you so much.
All right, thank you very much to the fourth team for your presentation and for finishing the Q&A portion. Thank you as well to our panel of judges for your questions and insights. Welcome back, everyone. Now let us call on our fifth team.
A mother's love is supposed to be a child's haven. But what happens when this turns into a child's worst nightmare? Good morning. This is a case of a 7-year-old female with the chief complaint of post-ictal loss of consciousness. Here are the salient features, the course in the ward, and the diagnostics. Our patient presented with confirmed subarachnoid hemorrhage. What could have caused this? Hematologic disturbances such as idiopathic thrombocytopenic purpura, hemophilia, von Willebrand disease, and vitamin K deficiency are considered due to the presence of multiple hematomas on the abdomen and upper and lower extremities. However, they are ruled out due to acceptable bleeding parameters. Westra and Colohan reports that 3 to 10% of cases of subarachnoid hemorrhages are caused by neoplasms, but the absence of weight loss, focal neurologic deficits, or slowly progressing neurologic dysfunction and tumor on the CT scan suggests another diagnosis. History of presence of foreign body in the ear could have predisposed our patient to have an infection, as in a case of otitis media, progressing to CNS infections such as meningitis or brain abscess. However, the absence of ear pain, discharge, hearing difficulties, or loss of balance rules out acute otitis media. Furthermore, typical symptoms of fever, neck pain or nuchal rigidity, photophobia, and other meningeal signs or focal neurologic deficits and CT scan finding of a walled-off lesion, as in the case of brain abscess, were not present, making CNS infection less likely. Trauma is the most common cause of isolated subarachnoid hemorrhage in the pediatric population in a study by Westra and Colohan. Although there is a report of slapping and shaking at the shoulders, a physical force of significant magnitude to the head, or in rare instances, a violent flexion extension of the neck, such as in whiplash injury, must be present, as mentioned by Adams and Victor. The absence of CT findings, such as skull fracture, retinal and subdural hemorrhages, point us to a less severe head trauma that could not have induced the hemorrhage alone. With the seemingly mild head trauma to our patient, can this still contribute to the development of subarachnoid hemorrhage? Without the benefit of CT angiography, the following common vascular malformations of the brain cannot be completely ruled out: arteriovenous malformation, aneurysm, cavernous malformation, and telangiectasia. A weakened blood vessel wall due to a malformation is susceptible to rupture when exposed to a significant trigger, such as a mild head trauma documented in our patient. Among these vascular abnormalities, arteriovenous malformations are still considered most frequent in childhood, as reported by El Ghanem and colleagues, even with a low estimated prevalence of 1 to 3 per million, as mentioned by Boulois and others. In addition, according to Nelson's, arteriovenous malformations are the most common cause of childhood non-traumatic subarachnoid and intraparenchymal hemorrhage and may occur anywhere. So what could have happened to our patient? The presence of pediatric abusive head trauma from slapping and shaking predisposed the patient to the rupture of an already existing arteriovenous malformation. Other pieces of evidence of child abuse include multiple hematomas in the abdomen and upper and lower extremities, decreased appetite, generalized weakness, and declining academic performance. The ruptured arteriovenous malformation resulted in bleeding in the subarachnoid space. The breakdown of blood activated the release of spasmogens and caused cerebral vasospasm, progressing to cerebral hypoperfusion that eventually led to cerebral edema. Concurrently, the release of epileptogenic products into cerebral circulation caused the seizure. The bleed also triggered an inflammatory response, resulting in leukocytosis. The cerebral edema caused rapid increase in intracranial pressure, progressing to uncal herniation. The advancing uncal herniation led to compression of other parts of the brain, as evidenced by fixed dilated pupils, deterioration in the level of consciousness, hyperreflexia, absence of Doll's eye and gag reflexes, and respiratory depression. Intracranial vasculature compression also caused ischemia on the hypothalamus, leading to hypothalamic dysfunction and temporary insulin resistance, as evidenced by stress-induced hyperglycemia and diabetes insipidus manifesting as polyuria, hypernatremia, and hyperchloremia. Moreover, the transient insulin resistance stimulated anaerobic glycolysis, resulting in decreased blood pH. The compression of blood vessels also led to overactive sympathetic activation that resulted in catecholamine excess. This would now cause neurogenic pulmonary edema presenting as crackles on bilateral lung fields. And stimulation of a beta-2 adrenergic receptor linked to sodium-potassium pump leads to hypokalemia. And lastly, myocardial hyperperfusion resulting in neurogenic stunned myocardium as evidenced by tachycardia and catecholamine-resistant hypotension. The persistent hypotension now caused hyperperfusion to organs, leading to multiple organ dysfunction, resulting in increased creatinine levels, decreased oxygen saturation, and low voltage cerebral activity. These ultimately led to the patient's demise. Our final diagnosis is multiple organ dysfunction, secondary to uncal herniation, secondary to subarachnoid hemorrhage, probably secondary to traumatic rupture of arteriovenous malformation with suspected child abuse. In a world full of possibilities, it should not hurt to be a child. Here are our references. Thank you very much.
Thank you to our presenters. Just a quick correction, this is actually the presentation of the 4th theme and not the 5th theme. I apologize. With that, let us now move on to our question and answer portion. Let's call on our first judge, Dr. Andrea Valley.
Thank you for that very interesting take on the case of the patient. So you think that this abuse has been going on for a long period of time, correct?
Yes, Doc. Good morning, Doc. Yes po, Doc.
Alright, sige, kasi... Okay, so... Wait lang. So, how would you explain the symptoms of the patient that occurred more than a month ago? How does that fit in the history of the patient?
Then a month ago, Doctor, you are referring to the ear
Yes, the ear, the
checkup
fever
po?
at that time, yes. How does it fit into the history of the patient? Do you think it's significant or not?
Considering that there is a suspected child abuse in the patient, it could be attributed to Munchausen syndrome by proxy when a parent tries to manifest symptoms and offers checkups to the pediatric patient in order to gain attention po. It can also be attributed po. But in the result of the checkup a month prior to admission, there is no ear inflammation. The fever subsided immediately. Points us not to a CNS infection, Doc.
Okay, but as you've said, Munchausen syndrome by proxy means that they did seek consult, and in this history, there was no consult for the fever, just for the ear, for the insect in the ear, and then no consults afterwards. Okay, so
yes, po, Doctor.
Munchausen syndrome by proxy. Now, my last question, sorry, 3, is that do you expect more? What are your expected CT scan findings on abuse? Is the subarachnoid hemorrhage enough evidence for an abuse leading to this kind of sensorium and eventual demise?
If it is the common blunt trauma, Doc, CT scan finding would suggest skull fracture or subdural hematoma, which did not present in our patient. That's why in our pathophysiology po, a relatively minor head trauma contributed, suggests an underlying cause for the subarachnoid hemorrhage po.
But was the subarachnoid hemorrhage enough in the patient's CT scan to give you this kind of sensorium?
Yes po, Doc. Although it's very hard to estimate the amount of blood in the subarachnoid hemorrhage, but it is not only the amount of blood that causes the mass effect to result in this sensorium. It is because we need to also consider the neurotoxic effects of the blood, because blood itself and other products such as thrombin, the free iron, the hemoglobin would actually cause neuron cell death. And from the neuron cell death, the cells would actually cannot maintain the homeostasis anymore, cannot maintain the ions, the neurotransmitters would actually leak, causing now the seizures. And then the blood products are also vasospastic. So from that, it would now cause the cerebral edema, causing the generalized or very severe sensorium in our patient.
Thank you.
Thank you po.
Thank you, Dr. Valia. Next, let's move on to Dr. Rodolfo now.
Yes. It was stated on admission the BP of the child was 80/40. So can you correlate that with what? Can you correlate that with the autosat of 97%?
Hello,
Sige,
good
sige.
morning po, Doc.
Ah.
Yes po. So, the persistent hypotension po might have been it could have from it's caused by the cardiogenic shock po. So, shock in its essential meaning definition po, it's the inability of the body to supply oxygen and meet the metabolic demands of the organs po, so, Doc. So because of that shock, then it would cause hypoperfusion to these organs and would also cause the decrease in autosaturation po.
So in other words, you agree that 80/40 for a 7-year-old child is shocking.
Yes po, Doc. If it's
So you agree?
Yes po. Yes
Let's
po,
say,
Doc.
for example, you don't have that table on hand. Diba? There is also a way for you to be able to know whether the blood pressure is shocky or not. Any idea? What is the formula? Okay, anyway, you mentioned that, yeah, you agreed that the patient is in shock. And from the ER, the doctor in charge or the resident who saw this patient kept giving 20 cc per kilo per dose. Any idea up to how many 20 cc per kilo can you give? And how are you going now to relate that to the presence of crackles in both lungs?
Doc, we attributed it to a ANS dysfunction, Doc, causing the hypotension, Doc, as in the diagnosis of neurogenic stunned myocardium po, causing hypotension po, and the neurogenic pulmonary edema presenting as bilateral crackles po.
Yeah, regarding yung 20 cc per kilo per dose to treat your what hypotension as a fluid challenge, no?
Yes po, Doc. We can also attribute it also as a
up to how many times can you give that 20 cc per kilo? Sige. Okay, I'm done. Sige, thank you.
All right, thank you, Dr. Rodolfo Nang. Lastly, let us call on Dr. Maria Cecilia Lim.
Good morning. Okay, I found your take actually refreshing. It was short and I found concise. A rhetorical question. In a case of child abuse, do you think you're going to get the truth out of a parent as to what exactly happened?
No, Doc. In the cases of child abuse, the parent would downplay the situation that he or she uh, will not be implicated on the abuses done to the child po.
I would agree with you on that. And that is actually why we do autopsies on cases suspected of child abuse, like in this case. Now, I think you mentioned earlier that the hematomas that you see or the intracerebral trauma that you see related to child abuse concerns mostly subdural hematomas. Would there be cases where you can only see subarachnoid hemorrhage?
Yes po. In in a case study that we read po, the presenting symptom is subarachnoid hemorrhage. However, there is a underlying cause such as AV malformation, and the trauma alone did not cause the subarachnoid hemorrhage. There's an underlying cause such as AV malformation or aneurysm, though.
I'm not sure how they edited the abstract that was given to you, but I think one of the clinicians in this case suspected a central diabetes insipidus. Was that information given to you? Hindi.
It is not given, but in our proposed pathophysiology po,
It was discussed.
Yes po, we discussed a central diabetes insipidus po.
Okay. So you think that the uncal herniation is more attributable to the subarachnoid hemorrhage versus the central diabetes insipidus?
Yes po, Doc.
Okay, just a last comment, because I'm already taking this opportunity to teach you how to write MCCODs. You cannot put two conditions in one blank. So you can actually move up your immediate cause of death to something like uncal herniation secondary to SAH, secondary to ruptured AVM. Okay, that's it. Thank you.
Thank you po.
Thank you po, Doc.
Thank you, Dr. Lim, and thank you to our presenters for their presentation and for finishing their Q&A portion. Thank you to our panel of judges for their questions and insights. Welcome back, competitors. Now let us call on the fifth team.
This is a case of a 7-year-old female who came in due to post-ictal loss of consciousness. Relevant history revealed that 1.5 months prior to admission, an insect lodged in her right ear. Half a month later, she experienced decreasing appetite and generalized body weakness. 2 days prior to admission, her poor school performance resulted to some physical abuse from her mother. A day after, she started experiencing tonic seizures. The length, reoccurrence, and the lack of response to anticonvulsants classifies this as a case of refractory status epilepticus. At this point, we consider the following differentials for seizures. Proceeding to the ER, she was seen comatose, a febrile but hypotensive and tachycardic, with multiple hematomas on the abdomen and extremities. CT scan also revealed subarachnoid hemorrhage, thus, the following causes are less likely. This leaves us with traumatic and spontaneous causes of subarachnoid hemorrhage. Under traumatic causes, child abuse should always be a suspicion because of her relevant history, the hematomas seen, and the possibility of abusive head trauma, leading to intracranial hemorrhage and seizures. However, 95% of intracranial hemorrhages are immediately symptomatic after the inciting trauma. Furthermore, the fact that these can be attributed to other etiologies and the lack of associated injuries makes this less likely. Under spontaneous causes, first, we consider infectious etiologies like viral encephalitis due to her relevant history. However, the chronicity of her manifestations, absence of prodromal symptoms, and her CBC picture makes this less likely. Second, Acute leukemia is a possibility, as abnormal leukocytic infiltration of cerebral blood vessels can cause aneurysms and thus rupture. However, hematomas in leukemia is due to thrombocytopenia, not seen in this case. In addition, the absence of blasts and anemia on CBC makes this less likely. Third, primary brain tumors are also considered. However, they are rare causes of pediatric subarachnoid hemorrhage, accounting for only 3 to 10%. The absence of other indicative signs and symptoms, the inability to explain the hematoma seen, as well as the absence of a mass on CT, makes this less likely. Fourth, the combination of easy bruisability and intracranial hemorrhages leads us to suspect acquired hemophilia due to the possibility of it being triggered by infections and concurrent illness. However, these are extremely rare in children, and APTT levels of greater than 100 seconds are usually needed to cause spontaneous arterial rupture. These features make this less likely. Fifth, ruptured AVMs are considered. However, these are rare in the pediatric population, accounting for only 3% of cases. This, along with unsupportive CT findings, makes this less likely. And finally, vascular Ehlers-Danlos syndrome is ruled in as the patient presented with extensive bruising and an arterial rupture, fulfilling the Villefranche criteria, needing at least 2 major diagnostic features. It is interesting to note that the characteristic fascies of this syndrome are only seen in 30% of cases. In addition, this subtype of Ehlers-Danlos is not associated with the joint hypermobility, unlike other subtypes, and it can occur sporadically. Lastly, this condition has been found to have concurrent abnormal coagulation profiles in 7.1% of cases. Thus, our primary impression is vascular Ehlers-Danlos syndrome. Now, let us explain what happened in this case. Sporadic mutations in the COL3A1 gene leads to decreased fibrillin production, causing the following effects. In addition, these mutations also cause aberrant folding of procollagen 3, impairing its secretion and deposition. All of these defects lead to the condition we know as vascular Ehlers-Danlos syndrome. Now, as type 3 collagen is widely distributed in the different organs, abnormalities in this protein causes structural fragility of these tissues, leading to the following manifestations. Moreover, the inherent alveolar fragility predisposed the patient to volutrauma upon intubation, manifesting as new onset crackles. In addition, the characteristic blood vessel fragility seen in this condition predisposed the patient to easy bruisability, manifesting as multiple hematomas on the abdomen and extremities. This fragility also increased the risk of vascular malformations such as aneurysms. In support, this study by Ziloki et al. Maps out the distribution of vascular abnormalities seen in VEDS, with these most commonly found in the head and neck. Now, as the arterial walls continued to weaken, rupture occurred, leading to subarachnoid hemorrhage. This triggered an acute systemic inflammatory response typified by neutrophilic leukocytosis. This bleeding foci also served as an irritant, disrupting neurochemical transmission in the brain, leading to refractory status epilepticus. Prolonged ischemic injury to the brain led to the following manifestations. This, along with cerebral edema, led to hypothalamic pituitary dysfunction. First, decreased blood flow to the posterior pituitary led to diabetes insipidus, manifesting with polyuria despite hypotension and electrolyte imbalances. Second, damage to the paraventricular nuclei and zone AB3B impaired hemodynamic control, causing refractory hypotension. This vicious cycle of continued hypotension further worsened ischemic injury and caused hypothalamic failure and loss of vascular tone, eventually leading to the patient's demise. This is our final diagnosis and our entry in the medical certificate of death. Finally, our references. Thank you.
Thank you to our fifth team. Now let us move on to our question and answer portion. May we call on Dr. Andrea Valle.
Congratulations to the team. That was well discussed. My question is, how do you explain the pulmonary findings of this patient with vascular Ehlers-Danlos?
Yes, doctor. With regards to Ehlers-Danlos syndrome, it is an inherent defect in the collagen tree, and judging from the initial mechanism of this condition, type 3 collagen is found in different tissues, such as the vascular wall, in the alveoli, and in the muscles as well. So in this case, judging from that fact, or knowing the pathophysiology of this condition, the patient can have inherent alveolar wall fragilities. So the weak alveolar wall upon intubation led to volute trauma because of the increased pressure inside the alveoli, leading to rupture, causing a systemic an inflammatory response locally and leading to interstitial edema, manifesting with new onset crackles.
So you're saying it was the intubation that caused the airway edema?
Yes, doctor. For us, this was due to ventilator or intubation-induced lung injury, as it was noted in the protocol that chest auscultation now revealed bilateral crackles on after intubation. And upon admission at the ER, it was noted that the physical examination of the patient, especially in the chest and lungs, were generally unremarkable.
Okay, thank you.
Thank you very much, doctor.
Thank you, Dr. Valle. Let's move on to Dr. Rodolfo now.
Yes. Yung previous group mentioned about Munchausen, no? Pero right now, they are now termed as factitious disorder imparted to others, no? In factitious disorder, usually the perpetrator seek consultation very frequently. Now, did you notice from the case protocol, what do you think aside from physical abuse, no? Yung slapping and shaking, did you not notice na there is also another child abuse pattern that is seen in this case? Hindi lang physical abuse.
Yes, doctor. So aside from physical abuse, other forms of abuse could also be considered, such as mental abuse, because this patient was, as this patient was an honor student, and the mother slapped her because of poor school performance. This could also be another form of abuse, setting high expectations for the child. And
so you mean mental abuse?
It could be a possibility as well, aside
Is
from
there,
physical abuse.
Is there such a thing as mental abuse?
Yes, Doc. RA 7610, or the Special Protection Against for Children Against Discrimination and Abuse, defines child abuse, and it considers mental, physical, sexual abuse. And so, to answer your question, Doc, yes, mental abuse is defined as as part of the child abuse law.
All right. So in relation to that, what you have mentioned about yung poor academic performance, what could be the why mother behave differently to this child due to poor school performance?
Yes, doctor, because in this case, we attributed the manifestations of this patient to our primary impression rather than child abuse, because we were thinking of other etiologies. First, as the history was relatively lacking for us to definitively rule in child abuse. So in this case, when suspecting Ehlers-Danlos syndrome, it has several studies that we have come across associated Ehlers-Danlos syndrome with generalized muscle weakness and fatigue, because type 3 collagen also composes the extracellular matrix of muscles, and thus leading to muscular weakness and fatigue. Of course, when a child is chronically fatigued, this could lead to decreased concentration in school and thus poor school performance. And so we attributed the poor school performance of this child to Ehlers-Danlos syndrome rather than child abuse.
And we would like to mention that vascular Ehlers-Danlos is considered a child abuse mimic, so it is important to be part of the differentials when presenting with a child with suspected child abuse.
So in other words, did I get it right? The group has totally ruled out child abuse in this case.
No, Doc. At this point, with the limited information, we cannot definitively rule in nor rule out child abuse at this point. To further rule it in, we would need further diagnostic tests, such as your X-ray to check for multiple fractures in different stages of healing. And in our case, since the patient has unfortunately expired, we could do our autopsy findings, post-mortem, and direct ophthalmoscopy to check for retinal hemorrhages. And we could also do our autopsy of the brain to check for the bridging veins in the brain to check if it is intact. Because if it is not intact, that would rule in trauma. But we could also check for the histological findings of our retina to check for intraretinal and intrascleral hemorrhage and subdural hemorrhage of the optic nerve. Without those findings, we cannot definitively rule in or say this is a case of child abuse.
Okay, thank you.
Thank you very much, doctor.
Let's now move on to Dr. Cecilia Lin.
Thank you, Group 5. That was a very interesting take on the case. Ehlers-Danlos is a very rare condition, especially in the Philippines. So actually, I think that's why Dr. Nang was asking all these questions, because I also had the impression that, am I correct? My impression may be wrong, but the bruising that was reported at the emergency room, you're not exactly attributing to physical child abuse?
Yes, doctor, with regards to the bruising, we cannot definitively rule out child abuse in this case if we do not have a further or more specific physical examination findings, such as to the location of these bruises, if these are found on the extensor surfaces, the specific appearance of these bruises, and the like. However, we were, again, with the approach of this team, with the lack of information on the history of this patient and the lack of other findings, we considered Ehlers-Danlos syndrome a little bit more, as it could also explain the hematomas that were seen. And again, as my teammate has mentioned, it is a very important mimic of child abuse and should always be considered in children who have hemorrhagic or ischemic stroke. So the presence of the stroke and hematomas from the literature that we have read is very much suggestive that we should consider Ehlers-Danlos as a main part of the differentials first, as a mimic of child abuse.
We would like to also emphasize that the classic triad of child abuse would be cerebral edema, subdural hemorrhage, and and retinal hemorrhage. Sorry, thank you. But in this case, this is subarachnoid hemorrhage, and for cases with intracranial manifestation of child abuse, 90 to 98% are subdural hematomas, and usually they manifest within minutes of the inciting trauma.
Okay, you mentioned retinal hemorrhage.
Yes.
Do you really expect to find that in a 7-year-old?
This is, yes, we can still check for retinal hemorrhages through indirect ophthalmoscopy, and this is still indicated in pediatric cases because this is specified for child abuse, whether it may be infants or school-age children or those until 13 years old. And findings for the retinal hemorrhages could be described as bilateral involvement, multiplanar, multiple hemorrhages seen, and this is highly suggestive. If these are seen, this is highly suggestive for child abuse.
Would you know what is the pathophysiology of the retinal hemorrhages in child abuse?
The rupture of due to the trauma that has been incited to the child because of abusive head trauma, this could lead to rupture of several intracerebral blood vessels. And aside from this, it could also increase intracranial pressure with the rupture of several blood vessels and the buildup of pressure inside the brain. It could cause the appearance or manifestation of retinal hemorrhages. seen in child abuse.
Literature would also suggest that intensive shaking, the exact force was not specified, but it was indicated that moderate to severe shaking or impact forces could cause the retinal veins to present as retinal hemorrhages.
Okay, actually, because the other group also mentioned this, no, the retinal hemorrhages are usually associated with shaken baby syndrome, and we don't usually see it in children who already have good neck control. And the only time we actually see the retinal hemorrhages in other instances of trauma is when you have a high-speed car crash. So this is actually infrequent, except in shaken baby syndrome. That's it. Thank you very much.
Thank you very much, doctors.
Thank you, Dr. Lim, and to the rest of our panel of judges for your questions and insights. Congratulations to our 5th team for their presentation and for finishing their question and answer portion. Welcome back to our competitors. Now let us move on to Team 6.
This is a case of an old female presenting with post-ictal loss of consciousness. She has a history of an insect lodged in the right ear, allegedly not removed, generalized weakness and loss of appetite, poor school performance, physical harm, new onset seizure, and a stormy course in the hospital. So how do we approach this? In pediatric patients presenting with new onset of focal seizure and abnormal neurologic exam, CT imaging should be done, which in this case pinpoints subarachnoid hemorrhage as the cause. Subarachnoid hemorrhage sufficiently explains the majority of salient findings throughout the patient's course after the onset of seizure. Taking this into consideration, subarachnoid hemorrhage in the pediatric population may be caused by the following. Neoplasms and hematologic malignancies are ruled out due to the absence of fever, lymphadenopathies, organomegaly, and laboratory findings of pancytopenia, hyperleukocytosis, and thrombocytosis. The normal hemoglobin, platelet count, and bleeding parameters, as well as the absence of heritable blood dyscrasias, do not favor coagulopathies as the cause. Although rare, vasculitides can explain the multiple hematomas and the subarachnoid hemorrhage. But the absence of hallmark findings like palpable purpuric rash and IgA vasculitis, which is the most common cause in children, makes this disease group unlikely. How about infection? Chronic and severe ear infection has been documented to cause CNS infections. These CNS infections like meningitis, encephalitis, brain abscess, and meningococcemia can then lead to subarachnoid hemorrhage and multiple hematomas. However, the absence of headache, fever, meningismus, altered consciousness, and the temporality of symptoms rule out infectious causes as the culprit. Traumatic injury should be taken into consideration as there is evidence in the patient's history of at least one episode of child maltreatment. It can explain the presence of hematomas in unlikely areas, such as the abdomen. However, traumatic injuries alone generally result to subdural hematomas rather than subarachnoid hemorrhage. Together with the absence of retinal hemorrhages that correlates with the degree of head trauma, although cannot be completely ruled out, traumatic head injuries alone is unlikely. So how do we explain the possibility of subarachnoid hemorrhage in the setting of a possible physical abuse? The presence of cerebrovascular malformations may be the culprit of subarachnoid hemorrhage in this patient, with trauma as the catalyst. Arteriovenous malformations are the most common non-traumatic cause of intracranial bleeding in pediatric patients, but the absence of persistent headache and localizing urologic signs lessens the possibility of this etiology. We are left with cerebral aneurysms. Although rare in children, the occurrence of cerebral aneurysms is still possible. A study reported that 65% of 52 childhood cases had already ruptured at the diagnosis. Subarachnoid hemorrhage in children is always suspected of traumatic aneurysm, since spontaneous aneurysms are very rare in children. The likelihood of aneurysmal rupture in the pediatric population is most commonly associated with head trauma, as implied in the patient's history. But before we continue, the gaps in knowledge we believe could be helpful in more clearly diagnosing the patient include complete history of the patient, like sudden onset headache, vomiting, localizing neurologic signs, and social history. Detailed physical examination findings, such as characteristic and pattern of hematoma and skeletal survey. Given the case as it is, our primary impression is subarachnoid hemorrhage, secondary to ruptured cerebral aneurysm, secondary to abusive head trauma. Child maltreatment is usually perpetrated by parents or primary caregivers and has been documented to cause a decline in school performance or cognitive function. The presence of multiple hematomas in obscure areas such as the chest, abdomen, and buttocks are commonly found in abused children. In approximately 5 to 10% of childhood cerebral aneurysms, the most common relation to its rupture is head trauma. The slapping and shaking by the mother 2 days prior to the onset of seizure and loss of consciousness may have caused the underlying aneurysm to rupture, leading to subarachnoid hemorrhage. Although sudden onset of severe headache is a key symptom in subarachnoid hemorrhage, there are cases where seizure and loss of consciousness are the initial documented findings in patients. Extravasated blood causes cerebral vasospasm and brain parenchymal irritation. This irritation caused the seizures. Repetitive and prolonged seizures fit the definition of status epilepticus, which can cause an increase in systemic catecholamines such as epinephrine and norepinephrine, leading to an increase in peripheral white blood cell count, explaining the presence of neutrophilic leukocytosis. Brain parenchymal irritation and diffuse ischemic injury lead to diffuse cerebral edema, leading to a cycle of decreased cerebral perfusion, ischemic injury, and increased intracranial pressure. If left untreated, these can cause cerebral herniation and eventually brainstem compression, which further contributes to this vicious cycle. Furthermore, seizure and diffuse cerebral edema, together with brainstem compression, affect the reticular activating system, leading to loss of consciousness. Cerebral and brain compression lead to the constellation of signs and symptoms seen in our patient upon admission. The loss of spontaneous respiration caused the patient's respiratory acidosis. But why do we see an initially low PaCO2? This can be explained by hyperventilation secondary to excessive minute ventilation due to continuous ambu-bagging. We also observed electrolyte abnormalities with increased serum osmolality and polyuria. This cluster of findings points to central diabetes insipidus due to hypothalamic insult brought about by the events happening in the brain. The absence of ADH results in decreased vasoactive response. This, together with hypovolemia and polyuria, contributed to the patient presenting upon admission with hypovolemic shock. Despite resuscitative efforts to reverse this, shock persisted. As a consequence, end organ damage occurred, as seen in the patient's metabolic acidosis and increased creatinine, representing acute kidney injury, and the multiple cardiac arrests indicating myocardial dysfunction, prompting multiple pressures and resuscitative attempts. The myocardial ischemia and subsequent myocardial stunning leads to decreased systolic dysfunction and pulmonary congestion, heard as crackles. And the result of persistent hypotension further worsens the patient's hypoxic encephalopathy. The devastating injury in multiple organ systems signifies multi-organ dysfunction syndrome, which would eventually lead to her demise. Our final diagnosis is multi-organ dysfunction syndrome secondary to traumatic brain compression with herniation, secondary to subarachnoid hemorrhage, secondary to ruptured cerebral aneurysm, secondary to abusive head trauma. Thank you for your kind attention.
Thank you to our 6 team. Let us now call on our first judge for the question and answer portion, Dr. Andrea Valle.
Thank you for that discussion. It was very well presented. My question is, do you think that based on the CT scan, was that enough CT scan findings to explain why the patient died?
Thank you very much for the question. The CT scan findings are actually insufficient for us to presume that the patient died because of that causes. However, the persistent or the presence of your subarachnoid hemorrhage with the presence of diffuse cerebral edema could explain the following symptoms that were presented in the patient. However, it would be most helpful, we believe, that the CT scan would also pinpoint the location of the subarachnoid hemorrhage, the degree of or the severity of the bleeding, and as well as other types of factors such as the presence of herniation, which was absent on the first day of the CT scan. So we believe that the CT scan itself is not supposed to be the underlying or the main reason for us to believe that that would be the cause of death of the patient or could explain the cause of death of the patient. However, it could explain the different events that was happening in the patient throughout the course until her demise. Thank you.
In addition to that, ma'am, a CT angiography or an MR angiography will be necessary to pinpoint if the cause of the subarachnoid hemorrhage is a cerebrovascular malformation.
Are there any other investigations you would have ordered for this patient? And what are those?
For the patient, we can actually, since we're thinking of abuse, we wanted a whole abdominal CT to look for signs of internal hemorrhage, since we didn't have a PE that may indicate any signs of tenderness. Another is skeletal survey imaging. We can look for other signs of fractures, green stick fracture, healed fractures, or any other indication that there is an abuse in the child.
Right. Thank you.
Thank you.
Thank you, Dr. Valia. Let's move on to Dr. Rodolfo now.
Yes, okay. As you can see from the protocol, do you think the impact of injury brought about by the slapping and shaking of the shoulder to the child would lead to the multiple hematoma noted upper lower extremities and abdomen?
Thank you for that question. Actually, since the reliability of the mother is in question, we cannot actually say that
Sorry. Did it say the percentage of reliability from the protocol?
Not po.
No, so you cannot make a presumption on that.
That's why in our gaps of knowledge, we wanted the description of the hematoma, the pattern of the bruising, the age of the hematoma. Since if there's like different ages of hematoma, it more indicates like a more chronic process of abuse in the child.
Additionally, sir,
yes.
Additionally, we did consider hematoma as as the symptom or as the presentation that would clinch our diagnosis. So among all the other diagnoses, we did consider if hematoma could fit the picture of the patient, but the laboratory findings that were given in the case say otherwise. So the vasculitides, the infections, the probable hematologic diseases, they all aren't seen, or the significant lab findings that you would expect to see in those kinds of patients are not present in this patient. So we were left with the final assumption of abuse, which, as seen in studies, can be present and won't have a likelihood of not being elicited directly from the primary caregiver, as the primary caregiver is usually the one that perpetrates the said abuse.
Okay. My next question would be, this is the same question that I throw to the other group. Did you not, have you not discovered what other child abuse pattern in this case, aside from physical abuse?
Though it's subtle, we have signs of neglect. For example, the lack of provision or the lack of engagement in child health promoting programs, such as immunization. In the patient, incomplete vaccination can be a sign of neglect. There's no MMR, no rotavirus, from what I remember. So
in relation to the current problem,
the poor school performance can also say that patient has been having psychological problem that can be due to the abuse.
What could be more obvious? You're right, meron ding element of neglect. Lalo na yung 1 month, 2 weeks, no? Prior to
Yes, sir.
Diba? Noting that the child has already manifesting on and off fever and general body weakness. Ano dun yung neglect? Did you notice?
From 1 month prior to admission, the patient has been having decreased appetite and generalized weakness, but in the interim, there was no mention of any consult or any intervention done for the patient.
Correct. Yeah, I agree with that. Sige. Thank you.
Thank you.
Thank you, Dr. Na. Let's move on to Dr. Maria Cecilia Lim.
Pagka-anticlimactic. Group 6, I actually found your presentation very straightforward. So I actually do not have any questions for you except for one comment. I hope you know sa death certificate, 4 lang ang linya. Thank you.
Okay.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Dr. Lim and the rest of the panel of judges for providing their insights and questions. And congratulations to Team 6 for their presentation and for finishing the Q&A portion.
Thank you.
Thank you very much.
Welcome back to our competitors. Let us now call on our 7th team.
Good day. Today we present a case of a 7-year-old female who was admitted for repetitive seizures with post-ictal loss of consciousness. There was a 6-week history of ear infection associated with intermittent fever, decreasing appetite, and generalized weakness, and a history of possible trauma to the head 1 day prior to the onset of seizures. At the ER, the patient was hypotensive, apneic, and comatose, with pertinent PE findings of multiple hematomas on the abdomen and extremities, as well as neuroexam findings suggestive of an upper motor neuron lesion with absent cranial nerve, motor, and sensory responses, and hyperreflexia. Now, what could have caused the patient's pathologic condition? In patients with history of seizure, proper characterization of the event is important. In this case, the patient had generalized onset tonic-clonic seizures lasting for 5 to 8 minutes. This was most likely provoked due to multiple possible triggers in the patient's history and is less likely to be unprovoked as in the case of epilepsy. The patient's seizures then progressed to status epilepticus, manifested as repetitive generalized convulsive seizures without regaining of consciousness interictally, reaching 5 minutes, after which treatment was initiated, but with no relief, likely due to underdosing of medications. According to Nelson's textbook of pediatrics, these are the major non-epileptic entities that cause status epilepticus in children. Acute intoxication can be ruled out due to the lack of ingestion of drugs or substances in the patient's history. Metabolic causes are also less likely due to normal glucose levels on the first day of hospital, and the hypernatremia with hyperchloremia on the second hospital day are more suggestive of an iatrogenic cause from the PNSS boluses given. An intracranial tumor is also considered due to the history of decreased appetite. However, this can be ruled out due to absence of mass effect seen on CT scan. Stroke as the cause of the seizures can be considered due to the acute temporality of the patient's deterioration and findings of subarachnoid hemorrhage on CT scan. However, according to Saflarsky et al., stroke usually presents with headache and focal neurologic deficits and only presents initially with seizures in around 8.4% of cases. Traumatic brain injury is also considered due to possible trauma to the head inflicted by the mother a day prior to the onset of seizures. This is important consideration, especially with the prevalence of underreporting of extent of insult in cases of child abuse. Thus, this cannot be totally ruled out and further evaluation is recommended. Lastly, infection is highly considered due to the 6-week history of a possible ear infection, followed by the following signs and symptoms. Considerations for infectious causes in this case can be narrowed down based on the chronicity of the patient's symptoms. Thus, diseases that present acutely or subacutely, such as acute bacterial meningitis and brain abscess, can be ruled out. Now, based on the temporal pattern of the patient's symptoms, chronic meningitis is considered, and most common among them is tuberculous meningitis. TB meningitis is highly considered based on its local disease burden, the patient's age group, and non-specific symptoms. Furthermore, the BCG vaccination at birth does not confer total immunity against TB meningitis. Although the occurrence of tuberculous meningitis in children is relatively rare, it can present with seizures if untreated and is associated with higher rates of mortality and severe morbidity. Now, in order to narrow down infectious etiologies and confirm the diagnosis, the following diagnostics can be requested. Now, let us trace back the key events of the case. From a primary Mycobacterium tuberculosis infection, likely in the lungs,
The infection spread hematogenously to the brain meninges, where they remained in dormant state. Early stages of meningitis are asymptomatic or associated with non-specific symptoms, such as generalized weakness manifested by our patient a month prior to admission. With further bacterial proliferation in the meninges, there is rupture into the ventricular and subarachnoid membrane spaces, resulting in breakdown of blood-brain barrier and vasculitis. This then led to occurrence of cerebral edema and subarachnoid hemorrhage in the patient, contributed to by the head trauma experienced by the patient. Subarachnoid hemorrhage, cerebral edema, and the history of traumatic brain injury were considered contributory factors that may have provoked onset of seizures and its subsequent complications. Now, what could have caused the patient's demise? Increased intracranial pressure due to the diffuse cerebral edema and subarachnoid hemorrhage likely led to uncal brain herniation, manifested as coma, fixed dilated pupils, hyperreflection, apnea, and intractable hypotension. In addition, septic shock also contributed to the patient's hypotension and metabolic derangements. Although inotropes and antibiotics were started, increased intracranial pressure was not addressed and herniation persisted, explaining the patient's intractable hypotension and rapid deterioration. All of these eventually led to the patient's demise on the third hospital day. Thus, the following represents our medical certification of the cause of death, and this is our final diagnosis. Thank you.
Thank you to our seventh team. Now it's time to proceed to the question and answer portion. Let's call on our first judge, Dr. Andrea Valle.
Okay, thank you very much for your presentation. It was very interestingly discussed. My question to you is, how do you explain the metabolic derangements of the patient?
Hello po. Can you
Yeah.
hear us?
Yes, yes. Now it's clear. Very good.
We apologize for the technical difficulties po. So for that answer, we attributed the metabolic derangements of the patient to an iatrogenic cause, given that the patient presented with hypernatremia with hyperchloremia and hypokalemia.
So what do you mean iatrogenic?
Iatrogenic specifically due to the PNSS boluses given, Doc. Yes. And
Is
then,
ABG consistent with the is the ABG consistent with the boluses, with giving a lot of plain NSS boluses? Sige, okay.
In addition, Doc, the metabolic acidosis of the patient. So metabolic acidosis of the patient can also be attributed to the apneic state of the patient. Doc.
All right, okay. Sige, thank you.
Thank you, Dr. Valle. Let's now move on to Dr. Rodolfo now.
Yes, yes. Okay. Hopefully, this will be clearer, no? Now, we had, from your discussion, we have to settle, no? Which do you really refer to, no? Kasi TBI, do you think TBI or traumatic brain injury is similar with abusive head trauma? Because you mentioned TBI in your what? Differential diagnosis. So, which is which in this case in particular?
we apologize, Doc. We actually read on abusive head trauma, and we considered abusive head trauma to be part of traumatic head injury, Doc.
Is that so? Is that what you read in the literature?
I think it should be two different entities, Doc.
Kaya nga. So how would you differentiate the two?
Traumatic head injury usually, Doc, through abusive head trauma, Doc. There is it is
Ano?
inflicted by someone else, Doc.
Okay. So in other words, it is what type? What is its intention?
Intentional, Doc.
Okay. All right. All right. But the other one, mostly?
Accidental, Doc.
Okay. Right. Now, well, your did I get it right? So your primary one of your primary diagnosis is TB meningitis, correct?
Yes, Doc.
Okay. So if you are the clinician or the attending doctor of this child, para lang to shall I say, to complement and strengthen your diagnosis, what other tests should be done here? Para to be sure, no, that this is TB meningitis. Kasi yung CSF hindi ginawa eh. So definitely we will be at a loss, right? We cannot make that as our basis. So ano pang yung nalaman ninyong test for TB meningitis?
From what we read, Doc, most of the confirmatory diagnosis for TB meningitis really requires CSF.
Yes, yun nga. For this case, impossible, right? Ano pa yung pwedeng gawin natin para to strengthen your diagnosis?
We can do, Doc, chest X-ray if we're considering that it began pulmonary. We can also do...
Yeah, pero hindi ba chest X-ray are non-specific?
EPA na expert, Doc.
Ano again? Again, yes. You're right na. Ano yun?
EPA na expert, Doc.
Ano pa? Ano pa isa? Yung tuberculin test may not be what? Accurate, right? Kasi non-specific. And many times, sa TB meningitis, yung PPD is usually what? Negative. Correct? Ano pa yung iba pang modality, test modalities? Available siya pero rather expensive. Nakalimutan na? Di ba IGRA? Just taking blood specimen will be enough. Okay? All right. Sige, that's all. That's all my question.
Dr. Na. Let's now move on to Dr. Lim.
Good morning, Group 7. Another interesting, unique, and yet expected take on the case. The running joke when we do autopsies is, even before we open the body, is, nako, TB lang yan. And yet, just a question on your style of diagnosing, and this is also because I noticed this with the other groups. Wouldn't it be safer to just call it like a chronic meningitis and then hazard a guess on the organism causing that chronic meningitis? What made you, go from a more generic term to a specific term as tuberculous meningitis? Nakamute kayo.
So, Doc, we considered specifying it to TB meningitis first because of the endemicity of tuberculosis in the Philippines, and also we have also read in one of the studies that most common etiologies or pathogens for chronic meningitis are atypical. So, and then the most common pathogens such as Streptococcus, Neisseria they present as acute meningitis. So for chronic meningitis, we considered TB meningitis because statistically it is the most common and based on endemicity in the Philippines as well.
To add lang po, Doc,
yes.
Just for presentation purposes po, Doc, to have a stand also on what was the most probable for us. But in terms of really having the official certificate of death, I think after we should write the positive organism after confirming its presence, also for epidemiological purposes.
Correct. Now, going to your final diagnosis, can you give us a proper cause of death statement? Because you gave a hodgepodge of 7 conditions, not exactly in any order. What is your cause of death statement? Blank, secondary to blank, secondary to blank. Or did I miss that?
For our medical certification of the cause of death, Doc, our immediate cause of death is brain herniation syndrome and CUL, secondary to status epilepticus and subarachnoid seizure, secondary to TB meningitis.
Thank you. Thank you.
Thank you, Dr. Lim, and the rest of our panel of judges for their questions and insights. And congratulations to our 7th team for their presentation and finishing their Q&A portion. Welcome back to our competitors. Let us now call on our final team, the 8th team.
A 7-year-old female was admitted due to post-ictal loss of consciousness. Her history includes an insect that lodged into her ear, managed with otic drops. Weeks later, she began to experience constitutional signs and symptoms and apparent cognitive changes, triggering her mother to hit her. On the day of admission, the patient had status epilepticus followed by loss of consciousness, hence the admission. Throughout the course, she had been in a comatose state with persistent hypotension and tachycardia refractory to management. CT imaging revealed a subarachnoid hemorrhage and diffuse cerebral edema. The following days showed progressive decline in various organ systems, which ended in her demise. From the patient's history and physical examination, important salient features are identified, warranting the investigation of infectious and non-infectious etiologies. Infectious etiologies are considered due to the following. CNS infections can present as meningitis, encephalitis, and cerebritis. In general, they manifest with fever, headache, meningeal syndromes, and seizures. However, the following manifestations are absent, and ear pathologies are responsive to otic drops. CNS infections generally present with fever and headaches. Therefore, infection of origin is less likely. To proceed, non-infectious causes are further explored. Considering the following salient features, vascular causes are now examined. Intracranial aneurysms are rare in childhood with about 0.5 to 4.6% in patients 18 years of age or younger. It is asymptomatic until it ruptures, causing the following manifestations. The estimated mortality after the first bleed is usually lower compared to adults. Subarachnoid hemorrhage is also better tolerated by children due to the low rate of clinically significant vasospasms. The incongruence between the patient's presentation and the typical characteristic of an aneurysm makes this diagnosis unlikely. Arteriovenous malformations of the brain are considered the most frequent abnormality of intracranial circulation in childhood. Although approximately 50% of patients initially present with bleeding and recurrent seizures, 21.5% can also present with headaches. Its location is typically within the brain parenchyma, resulting in intraparenchymal hemorrhage. AVMs in the pediatric population tend to rupture at around 15 to 20 years old, resulting in only 5 to 10% chance of death. The following points mentioned are not in accordance with the patient's remarkable factors, making this diagnosis less convincing. With the limited data given in the case, localization of a brain tumor is challenging. However, if the basis would be on the patient's symptomatology, the lesion could be supracellular. Pediatric brain tumors of the suprasellar region share similar presenting symptoms due to the shared anatomic location and close proximity to the following structures. With the patient's history, physical findings, and progression in the ward, pediatric suprasellar tumors are the likeliest to be considered. Statistically, the main pediatric suprasellar lesions are craniopharyngiomas, optic gliomas, and germinomas. Craniopharyngiomas often present with endocrine dysfunction of growth hormone deficiency, while the majority of optic gliomas manifest with visual disturbances. Germinomas are known for diabetes insipidus. The patient had a slow-growing suprasellar tumor initially manifesting in the patient as generalized body weakness, loss of appetite, and sudden poor performance. A characteristic of suprasellar tumors are central diabetes insipidus due to compression and disruption of the vasopressin pathway, resulting in low ADH levels, evidenced by high urine output causing hypernatremia. The tumor released different angiogenic factors promoting the growth of poorly formed vessels, which are susceptible to rupture and bleeding. Combined with hypernatremia, the fragile vessels ruptured as seen as subarachnoid hemorrhage. Hemorrhage-induced apoptosis, necrosis, and autophagy resulting in neuronal cell death, releasing DAMPs. Now, entering the circulation causing systemic inflammatory response syndrome evidenced by leukocytosis and hyperglycemia from inflammatory cytokines. From the systemic inflammatory response syndrome, the prolonged APTT and multiple hematomas were now suggestive of disseminated intravascular coagulopathy. The degradation products of subarachnoid hemorrhage increased neuronal activity seen as status epilepticus. The ongoing hemorrhage was accompanied by a diffuse cerebral edema, complicating to brain herniation observed as brainstem dysfunction from ischemic damage and autoregulation impairment. Systemic inflammatory response syndrome and low vasopressin synergistically resulted in refractory hypotension despite tenacious fluid resuscitation and inotropes. The patient's organs were beginning to diminish as manifested in her renal, hematologic, cardiac, and pulmonary systems with cardiopulmonary arrest as the finding separately. This is a case of a 7-year-old female initially presenting with post-ictal loss of consciousness, followed by a rapid deterioration due to a silent and insidious tumor growth culminating in her final breath. The final diagnosis, immediate cause, multi-organ dysfunction, underlying cause, refractory hypotension with an antecedent cause of a subarachnoid hemorrhage secondary to suprasellar tumor. Thank you.
Thank you to our eighth team. Now let's proceed to the question and answer portion. Let's call on our first judge, Dr. Andrea Valle.
Hi, good morning. Thank you for your very clearly presented case discussion. So my question is the CT scan finding consistent with your diagnosis? You said
Although the CT
tumor, yes.
Yes, doctor. Thank you for that question, doctor. Although the CT scan was not did not seen the tumor was not seen in the CT scan, the subarachnoid hemorrhage and the diffuse cerebral edema could have masked the presence of a tumor in the CT scan.
Also, doctor, germinoma in imaging may be initially normal, and if diagnosis is suspected clinically, a close follow-up is required in order to identify potential, very subtle, abnormal thickening and enhancement of the pituitary stalk.
So you think that given that the patient died and the course was very fast, you think that this is a germinoma that isn't going to be seen on CT scan? All right. My other question is, how do you explain the pulmonary findings of the patient?
The pulmonary findings of the patient, which is the presence of bilateral crackles, could be because of the pulmonary congestion that could have been because of the rapid administration of fluids. And also, it could be a sign that the heart is already decompensating, causing pulmonary edema, doctor.
And the cardiac decompensation will be from?
The cardiac decompensation would be from the refractory hypotension, doctor, that was not improving even with multiple vasopressors.
So you're saying that the heart is, why would it decompensate? Why would hypotension give you decompensation?
Since because hypotension causes compensatory tachycardia, eventually the prolonged tachycardia will cause diminished function of the myocardium of the heart, leading to decompensation, doctor, and eventual decrease in cardiac output.
I beg to correct you na the heart will decompensate, giving you hypotension in the patient. Otherwise, there are other causes of hypotension na, which may or may not be discussed later. So, yun lang. Thank you.
Thank you, doctor.
Thank you, Dr. Valiant. Let's move on to Dr. Rodolfo now.
Yes, my first question will be very basic. If you are asked to be the historian of this case, no? You go back to the mother and then take a good history taking. What do you think would be the chief complaint? Kasi remember, yung post-ictal loss of consciousness is, to me, is not the normal run of the mill, no? Tsaka yung parang very scientific, no? So what do you think? What could be the chief complaint in this case?
Based on our pathomechanism, doctor, if we are given a chance to have a history with the mother of the patient, it will be the chief complaint will be a polyuria, since supracellular tumors, 41% of all cases with supracellular tumors usually presents with central diabetes insipidus.
So bali parang you are saying yung chief complaint would lead you to the diagnosis of diabetes mellitus. Now, if you're going to go back to the history presented in the case protocol, what do you think would be well, I cannot say appropriate, but the usual run of the mill? If this mother will bring the child to the ER, anong magiging chief complaint?
The chief complaint of the patient, doctor, will be seizures, doctor, since that was the cause of the patient's loss of consciousness.
Yes. So what kind of seizure? You have to elaborate on that.
So
let's say for example, if the mother does not know that the one that is being presented by the child is seizure, so what could have been her word about it? Because I remember in such chief complaint, we should not imply yung what you want to conclude kung ano yung chief complaint, di ba? It should be taken from the words, no, of the mother or the caregiver. And
if we relate it to the seizures, doctor, then the chief complaint of the mother would be stiffening and shaking of the patient. Doctor.
Tsaka ano pa? Qualify
and the
pa.
rolling of eyes upward, doctor.
Yes, there. No? Di ba continuous?
Yes, doctor.
Nung nag-transfer sa PGH, pangatlo na atang seizure. Okay. So my last question is, at that point in time, at the ER, the patient is comatose already, right? Or was comatose at that time. Do you think, will you be able now to clinically differentiate meningitis from encephalitis?
At that point, since the patient is already comatose, it will be difficult to differentiate meningitis from encephalitis because the patient's reflexes or the patient is not conscious. That leads to the signs and symptoms of meningeal irritation to be less observed, doctor.
Okay, good. Okay, thank you. Thank you.
Thank you,
Thank you,
doctor.
doctor.
Thank you, Dr. Na. Let's now proceed to Dr. Lim.
Good morning, Group A. Um, Thank you for your interesting presentation. Just one question. Do you think it's just a subarachnoid hemorrhage which precluded the hypotension in your so-called underlying cause of death, the suprasellar tumor? What would be the other mechanisms for the hypotension?
Thank you for that question, doctor. Based on our pathomechanism, the refractory hypertension was not due to the uh, subarachnoid hemorrhage, but was due to the systemic inflammatory response syndrome from the neuronal cell death, leading to this systemic inflammatory response syndrome.
In addition to that, doctor, we have discussed that the refractory hypotension of this patient is multifactorial. So since we are considering the presence of central diabetes insipidus because of the mass, so that could have contributed to the hypotension of the patient, doctor.
Thank you.
Thank you, doctor.
Thank you, doctor.
Dr. Lim and the rest of the panel of judges for your questions and insights. And congratulations to our 8th team for their presentation and finishing the Q&A portion. And that ends the presentations of our national finalists. I'm sure all of you are excited to know the final diagnosis of the clinical case. So without further ado, may we have our pathologist for this year's national CPC competition, Dr. Maria Cecilia Lim.
Okay, shall we begin? I actually haven't finished grading, but might as well start. Okay, so good morning again. Before we begin, as is my usual routine, I try to remind people what we look for when we have these CPC activities. Our primary goal is to see how you reach a logical diagnosis based on the information, complete or otherwise. Basically, the information we gave you was the same thing they gave us before the autopsy, except for one paragraph of the information given to you. Consultants always joke and say that CPC cases were not meant to be solvable. Some are, but the really good ones are meant to keep doctors on their toes, because when a consultant knows that it is a CPC case, and I'm sure you have the same thinking, they know that everything is not how it seems. The case is not just straightforward. And as such, we get to flex our brain muscles. And that's why for CPC contests, we try to choose a case that's kind of unsolvable. The reason is, aside from the aforementioned, is that it also allows us to check if you're just guessing about the case instead of arriving at a conclusion that's logical. Let me give you an example. When, for example, you're thinking of an infectious disease and you give as your diagnosis the third most common organism causing pneumonia, for example, instead of the most common, despite all these organisms presenting with the same symptoms and lab results, that's not logical. That's kind of guessing. In consultants, we call that gut instinct, but we're not exactly sure if there's room for that in a CPC contest because you're still students, which is why I always tell the organizers, try to remove the criteria for getting the correct diagnosis, because your score here is supposed to be kind of zero. Okay, so again, this is a contest of logic and on a minor scale, presentation skills. Okay, that said, let's go to your autopsy case. Next slide, please. The body received for autopsy is that of a fairly developed and fairly nourished Asian female, appearing about the recorded age of 7 years. Now, next slide, please. There is post-mortem lividity noted posteriorly, that is, and that's the pink areas that you see on the shoulders, on the lower back, with sparing of the buttocks and the area of your scapula. And I'm pointing this out to you because this is frequently confused with or hides. Next slide, please. Contusions. There are multiple contusions found on the body. There's a 1 cm in diameter purple-black contusion, so it looks kind of recent, consistent with the history of a 2-day assault by the mother on the right cheek. Next slide. There's another contusion on the left cheek and the left mandibular area, which I think you can see clearly in these photographs. Next slide, please. There are also contusions on the right deltoid. Next slide. On the lower legs, we're on the chest. There's also some on the abdomen. There's also some on the left upper arm. Next slide, please. And then you also have some on the left chest. So these contusions, although recent, are not of enough severity to actually have caused the death of the child, or at least contributed. So now we're going to go on the internal examination findings. Let us begin with the lungs, which were on gross examination about 20% heavier. Oh, sorry, I have more pictures pala. Next slide, please. A few more contusions on the lower legs. Okay. Now, this is a photograph of the lungs. The lungs grossly were about 20%, just 20% heavier and more solid than the usual. The microscopic sections show this. You have several inflammatory cells within the alveolar spaces. They are predominantly neutrophilic rather than lymphocytic or histiocytic. Next slide, please. This is just higher magnification of the previous photograph, showing you the inflammatory infiltrates, again, predominantly of the neutrophilic type. The diagnosis for this organ is bronchopneumonia, which is moderate to severe. By the way, there is also about 100 cc of serous sanguineous fluid found in the pleural cavity. Now, the next organ that we are going to talk about is the brain. Next slide, please. Now, going to the head, examination of the ear canals showed no discharge in the ear canal. We also didn't find any insect. Now, on reflection of the scalp, and this is the photograph you're looking at, note the absence of hemorrhage on the scalp and on the skull bone. The blood here that you see, the scanty blood that you see more on the posterior half of the skull, is more from the dissection. There is also no fracture. Next slide, please. In this photograph, the skull bone has been removed, and you're looking at the dura. There is no epidural hemorrhage here, nor is there any subdural or subarachnoid hemorrhage. Next slide. This is the base of the skull, showing the absence of fractures. Next slide. This is a photograph of your sella, showing you more or less dead center, your pituitary gland in situ. It is of normal weight, but it is softer than usual. Next slide. The brain weighed 810 grams. It's slightly heavy, and it showed diffuse edema with flattening of your gyrus and narrowing of your sulcus. The meninges showed patchy clouding or some form of opacity over the cerebral hemispheres, although cut sections did not show any parenchymal hemorrhages nor masses. The gray and white matter were distinct, and there was no hydrocephalus. Next slide. So this is a microscopic section of your brain. That's most of the picture in the lower part, with a portion of your meninges above it. The one you see in the upper portion of your slide. And in this photograph, you see some hypercellularity there because there are actually lymphocytes on the brain and in the parenchyma. Next slide, please. This is deeper in your brain. Dead center, you have vascular spaces with also some cells around it. Next slide, please. This is just a higher magnification of the blood vessels. And next slide. You see that these cells are actually comprised of lymphocytes and other mononuclears. I don't see any neutrophils in this particular photograph. This is actually what you call perivascular lymphocytic coughing. So this is a case of meningoencephalitis, probably viral in origin. We did not find any chronic granulomatous inflammation, which would tell us that this was tuberculosis. Now, next slide, please. This is a photograph of the pituitary gland. On the bottom right quarter of your screen, you see a very dark area compared to the rest of the cells. Next slide, please. Okay, you see that in this particular area, which is a highlight portion of that dark area, you see that the cytoplasm is darker than usual, and a lot of the cells do not have nuclei anymore. So these cells are dead and or dying. I think you can see that. Do I have another picture? I think that's the last. So you have dead or dying cells here. And the next photograph is a scanning view of the pituitary gland. Most of the periphery of the picture that you see here shows necrosis. Okay, so about 40% of the parenchyma of your pituitary gland is actually dead, although we didn't find any hemorrhagic areas. So the diagnosis here was pituitary gland necrosis or ischemia. And next slide, please. The final diagnosis was given as meningoencephalitis, probably viral, with pituitary gland ischemia as a complication. You have bronchopneumonia, moderate to severe, bilateral lungs with pleural effusion on the left. You have multiple blunt force injuries. The contusions, the area of contusions are just listed down here. There are small, by the way, abrasions on the index finger and the left upper extremity, but they're very minor. And there's a minor non-specific fatty change in your liver. Next slide, please. So the cause of death was signed out as hypovolemic shock secondary to central diabetes insipidus, secondary to pituitary gland ischemia, secondary to meningoencephalitis. And next slide. The manner of death was signed out as natural. Instead of homicide, although the mother was charged with child abuse and steps were taken to protect the sibling of the deceased by the social welfare personnel. Next case. Next slide, please. Sorry. So this is just a rehash of the history. Based on the history, what I believe happened, and this is just a reconstruction and is very subjective, is that the patient had meningoencephalitis, probably viral. You might call it a chronic meningitis. And you can actually attribute some of the symptoms from a month prior to demise as being a symptom of that chronic meningitis. So that might have started maybe a month ago. But the meningitis or meningoencephalitis progressed and caused pituitary gland ischemia, a rare complication of meningitis. And this is the one which may have given rise to the symptoms 2 days before the admission. And we believe that the seizuring, which is actually seen in central diabetes insipidus because of the dehydration, is central to the reason why this patient was admitted to begin with. Now, most of you diagnosed or discussed diabetes insipidus, so we're going to skip the next slides. Can we skip 2 slides, please? Okay. Some of you discussed this already, so I do not want to rehash this. Next slide. So I think most of you also discussed this, so we'll skip that one. So I'm going to jump to probably the last slide. Oh, by the way, just a note, pituitary gland ischemia may result in hypoparathyroidism from traumatic brain injury. However, it is not supported by the autopsy finding of the lack of injuries. So can we just go to the, okay, here, bronchopneumonia. Okay, the student also had the bronchopneumonia. However, the onset of the crackles, if you notice, was just shortly before the demise. And because of the shortness of the duration of the hospital admission, we were not able to culture or do any isolation or documentation of the etiologic organism, whether for the bronchopneumonia or even for the meningitis. But one possibility, and this is what we're leaning onto, is that it is hospital acquired, although some clinicians would argue that there's also the possibility of aspiration pneumonia because of the multiple seizure episodes. The pneumonia is probably bacterial in origin, given the predominance of neutrophils in the lung infiltrates, and it is supported by your elevated WBC count with the neutrophilic predominance. Next slide, please. Meron pa ba? Okay, now, I think something has to be said about the CT scan interpretation of the subarachnoid hemorrhage, because we did not see it on autopsy. We can't say it disappeared kasi masyadong mabilis yun, no? So just a note, imaging studies are not perfect even these days. Our radiologists are great, but they're still interpreting shadows literally and figuratively. And this is why even when forensic radiologists say we can replace the autopsy with a complete CT scan or MRI of the whole body, forensic pathologists just go, hindi. Our new imaging modalities are great, but they still cannot see everything. I've seen autopsies where PET scans showing absence of tumors in lungs and the liver, etc. But when you do the autopsy, you see numerous tumor nodules everywhere. I've also seen cases where the clinician goes, this is a case of so-and-so because the symptoms are so characteristic. The radiologist goes, hindi yan because I don't see it on the plates or the digital images. And then the autopsy shows that the clinician was correct. Okay, so we have many variations of these situations like this. Bottom line, if God forbid your patient dies, I would still push for an autopsy. It will not only be educational for you and your colleagues, but it is a quality control check for you as well. I think I answered most of your other issues. That's it. Thank you.
Thank you so much, Dr. Lim, for presenting the diagnosis of our clinical case. That was quite a difficult and tricky case for all of us. I'm sure everyone here is just as amazed for the final diagnosis as I am today. Now, to formally close today's program, may I call on the National President, Mr. Jenken Philip Carrado.
Magandang araw sa inyong lahat, ating mga manlalahok, sa ating mga eksperto at dalubhasang doktor, mga miyembro ng kagawaran ng Association of Philippine Medical Colleges Student Network, at sa lahat ng bumubuo ng National Clinical Pathologic Case Conference Competition. Isa sa adhikain ng Association of Philippine Medical Colleges Student Network ay ang siyang maging isang lugar upang ang mga kapwa namin estudyanteng doktor ay makapagpakitang gilas sa kani-kanilang kagalingan at talino sa larangan ng medisina. Gayon din, ang isang maging abenida upang magtawid ng kaalaman at makapagbigay linaw sa ilang mga katakatakang kaso na mayroon sa ating larangan. Sa araw na ito, mula sa tanggapan ng Pambansang Pangulo at sa lahat ng kagawarang bumubuo ng Association of Philippine Medical Colleges Student Network, taos-puso kaming nagpapasalamat at nagpupugay sa inyong mga kapwa namin estudyanteng doktor para sa isang masigabong araw ng paligsahan. Lagit-lagi para sa isang malaya at mapagpalayang sistemang pangkalusugan at edukasyong pangmedikal. Padayon sa lahat.
Thank you to our National President for that wonderful speech. Lastly, we would like to thank our panel of judges for gracing us with their presence and providing their deep medical knowledge. To our competitors for their participation, hard work, and splendid and creative presentations. And of course, to the Academic Competitions Committee, Conventions Committee, and the National Executive Board for making this competition possible. To our finalists, I know you are beyond excited to know who won this year's National Clinical Pathologic Case Conference competition. Unfortunately, we would have to prolong your excitement for a bit longer. The final announcement of winners will be during the first Gawad APMC-SN in the 5th National Convention on April 10, 2022. Please encourage your friends and colleagues to register for the 5th APMC-SN National Convention via our official website, apmc-sn.com, and get a chance to win very exciting prizes. Once again, this has been your host, Fretulin David. Thank you and good morning.